Good morning, Member Tebow. I've promoted you to a panelist. If we can do a microphone and a camera check.
Good morning.
Good morning. Perfect. Thank you.
Thank you.
Good morning, Jennifer. I've promoted you to a panelist. If you want to do a mic check, please.
Good morning. Doing a mic check. How does it sound?
Perfect. Thank you.
Thank you.
Good morning, Member Crowley. I've promoted you to a panelist. If we can do a microphone check and a camera check, please.
Good morning. Can you hear me?
I can hear you.
Okay, I'm actually going to put my my headset on, so I'm going to see if you can still hear me. One moment.
Okay.
It is 9 a.m. We're going to get started here. Welcome back. Cesar, are we good to go? Thank you, Cisco lady. I love that new voice. Day 2, welcome back to the November 5th or 6th, 2025 board meeting. My name is Sung Oh, president of the board. Before we convene, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with our interests with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. As the agenda details, the board has significant business to complete today, including significant business to complete today. Luckily, we did complete all the time-sensitive closed session items, and to ensure the board, bless you, our treasurer Chandler, to ensure the board has sufficient time to complete all of its necessary work, I have advised the meeting moderator to allot 3 minutes to each individual providing comments. We'll begin with public comments for individuals attending in person, in Anaheim, followed by public comments by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I would like to ask staff moderating the meeting to provide general instructions. I believe today is Shelley again.
I am back.
Okay, thanks, Shelley.
You're welcome. When public comment periods are open today, if anyone would like to make a comment, please click on the hand icon, which is typically located at the bottom of your WebEx screen. If you're on a mobile device, you may need to click on the ellipses or 3 dots to access the hand icon. And if you are a calling user, you can press *3 to raise your hand and then again to lower it. Instructions will be on the screen when we open public comment. I will call each person by their name and send a request to unmute your microphone. Each person will have 3 minutes to speak, and we will be providing a 10-second warning. We will also be displaying a countdown on the screen. Our call-in users can press *3 to raise their hand, as I mentioned, and then *6 to unmute their microphones. We will attempt to call on people in the order in which they raise their hands. And again, we are asking everybody to only speak 1 time per agenda item today. And I'll turn the floor back over to President O.
Thank you, Shelley. I would also like to remind individuals participating in the meeting via WebEx that consistent with the board's policy and with implementation of the board's new learning management system, pharmacists and pharmacy technicians attending the meeting via WebEx today may be awarded up to 6 hours of CE. Please review the information on the agenda and follow the instructions provided to ensure you are eligible. You'll be required to register through the board's learning management system, PharmEd. And also, I'm happy there's few attendees, so make sure you collect your CE. 6 hours per renewal cycle is my recollection. So that's a good number of CE to earn. So hopefully you stay for the whole meeting. I would like to take a roll call to establish a quorum. Jesse Crowley.
Licensee member present. Do you have to read off the screen as well? One moment. And there are no other individuals 18 years or older present with me in this room at this time.
Jesse, you sound a little soft, also a little robotic-y, just a heads up. So hopefully that gets resolved.
Okay.
Trevor?
Present.
Thank you. Renee?
Licensee member present.
Thank you, Renee. Jeanette Dong?
Public member present.
Thank you, Jeanette. Jeff Hughes is not joining today. KK Jha?
Licensee member present.
Thank you, KK. Claudia Mercado? Claudia?
Present, and there's no
Thank
other
you.
individuals 18 years of age or older are present in the room with me at this time.
Thank you, Claudia. Jay Newell?
Public member present.
Thank you, Jay. Ricardo Sanchez?
Present public member.
Thank you, Ricardo. Satinder Sandhu?
Licensee member present.
Thank you, Satinder. Maria Serpa?
Licensee member present, and there are no individuals 18 years of age or older present in the room with me at this time.
Thank you, Maria. Nicole Tebow?
Licensee member present, and there are no other individuals 18 years or older present with me at this time.
Thank you, Nicole. And I am here. A quorum has been established. I truly appreciate everyone's time and commitment to the board and California consumers. Again, we have a very full meeting as always. I ask everyone participating today to be respectful of the work before the board. We encourage participation by members of the public throughout our meeting at appropriate times. The board respectfully requests that when comments are provided, they're done so in a professional manner consistent with how board conducts its business. And before we move to the next agenda item for the day, I would like to remind board members participating via WebEx to please remain visible on camera throughout the open portion of today's meeting. If you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off your camera. I know there's somebody raised their hand on WebEx, but just a friendly reminder, we are not doing public comment today on items not on the agenda, as that was yesterday. So we're getting started with our first item for the day, which is agenda item 9, discussion and possible action related to proposed amendment to California Code of Regulations, Title 16, Section 1708.2, related to discontinuance of business, including review of comments received during the third 15-day comment period. Members, the meeting materials include background on the rulemaking package initiated by the board to amend Section 1708.2 related to discontinuance of business. You'll note from the meeting materials that following initial adoption of the regulation text, the Office of Administrative Law, OAL, requested that the board further clarify language. The changes requested by OAL were consistent with the board's policy and generally reward language and restructure the text of the regulation. The requested changes did not alter the requirements. Consistent with the direction from the OAL, staff initiated the 15-day comment period, which ended on October 22nd, 2025. No comments were received during this additional comment period. In addition to the cover memo for this agenda item, the modified regulation text is provided as well as historical version
I'm sorry, we can no longer hear you. Is that just me or is there something going on in the
No, I
room?
couldn't either.
Okay. I heard unmute. Okay.
All we heard was historical versions, and that's it.
Okay. I'm just gonna let's look. So I'm just gonna restart there. In addition to the cover memo, the modified regulation text is provided as well as historical versions of the proposed text noticed throughout the rulemaking. Action is required by the board today to complete the rulemaking record. This was started in April 24th of 2024, so it was not as long, but still long, but we're almost here. So you'll note there is a possible motion which is included in the meeting materials and displayed on the slide. And so, members, I welcome your comments and also entertain a motion if you believe such action is appropriate. And I note that is Jennifer on, Robbins? Our regulation counsel is available as well. I think she's on, but
I'm on, yes.
Thank you, Jennifer. My WebEx got disconnected here. So I'm going to have to rejoin that. I guess the hotel Wi-Fi is a little rocky. All right. Members? I'm not joining the WebEx. My internet's down. We need a motion, members, not to put anybody on.
So you can't
I'll
see
make
our
a
Thanks,
motion.
hand?
Maria.
Sorry.
Thanks, Maria.
And I can second that.
So let me read it. I'm sorry. I guess you can't see our hands, Sung, sorry.
Sorry,
to
I'm
ratify the
having a
mod-
little technical
That's okay.
difficulties here, so I'll
Move to
join.
ratify the modifications to the regulation text published during the third 15-day comment period from October 6, 2025 through October 22nd, 2025, and direct board staff to take all steps necessary to complete the rule-making process.
Thank you, Maria. And Claudia, you second?
Correct.
Sounds good. Members, do we have any other comments before we go for public comment? Seeing none, I don't have Jesse on the screen, so I can't see, but I think we're good. Oh,
I think we've
get
lost
all
Jesse.
of-
I don't
Yes, we
see her.
lost Jessie. I'm watching for her to rejoin.
God, you know, year 2025, still having technical difficulties. Story of our lives. All right. Well, I think we're gonna go for public comment. I think that's benign. So we're gonna go for public comment in person in Orange County for this agenda item 9, discontinuous business regulation. Nobody is here to walk up, although our room is relatively full, so I'm very happy. Thanks for coming, all of you. We're ready for public comment in WebEx.
All right, if you'd like to make a comment on this item, please raise your hand. You can locate that hand icon at the bottom of your screen, as mentioned earlier. You may need to look for the 3 dots if you're on a mobile device, and if you're calling in, you may need to dial *3. Give just a moment for individuals to chime in and raise their hand. And not seeing any requests, I'll turn the floor back over to you.
Thank you, Shelley. We're ready for vote. Jesse's not on. So we're gonna go to Trevor.
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, KK?
Yes.
Thank you, Claudia?
Yes.
Thank you, Jay?
Yes.
Thank you, Ricardo?
Yes.
Thank you, Satinder?
Yes.
Thank you, Maria?
Yes.
Thank you, Nicole?
Yes.
Thank you, and I vote yes. The motion passes. Next, agenda item 10, discussion of proposed changes to application questions for individual licenses and possible action to initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1793.5, related to pharmacy technician application. As included in the meeting materials, the federal Lorna Breen Healthcare Provider Protection Act was enacted in March of 2022 to address mental health challenges faced by healthcare professionals. The act included several components with the goal of reducing stigma, enhancing support systems, and ultimately improving the well-being of healthcare workers. By way of history, the board previously considered this issue and agreed the board should update its questions consistent with best practices. Subsequent to this direction, staff initiated changes and sought review and feedback by the representatives of the Wellbeing First initiative stemming from the act. Staff received feedback and additional changes to the questions were recommended. With this additional feedback, staff can move forward to update the questions on several application forms consistent with this feedback without formal action by the board, as we already formally approved that process. But today for our consideration are proposed changes to the pharmacy technician application, which is incorporated by reference in section 1793.5. Given that the application form is incorporated by reference, the formal rulemaking process is necessary to update the application form. You'll note that in addition to changes to the application questions related to mental and physical health conditions, staff are recommending additional changes to the application that are non-substantive, seeking to remove instructional language in the application form itself in favor of including such information in the application instructions, as well as updating the educational affidavit to provide clarity and ideally reduce deficient applications stemming from possible confusion. The revised application also reflects the updated questions regarding mental and physical health questions. I do believe the general feedback is technician application has pretty high deficiency rate, so I would also like to welcome any feedback that would be easier for the applicants to follow along. Included in the meeting materials are changes to the application form. While I note it looks like a significant number of changes, I do agree with the recommendation from staff regarding the non-substantive changes, and of course, as well as changes with the our questions that are being asked related to the mental health stuff. So including the meeting materials are changes of the application form. And so hopefully members, do we have any comments, any questions, concerns? I see Jesse's back. That's good. Need a motion though to propose a rulemaking. So if anybody's willing,
Hi, President O, this is Nicole. I have a comment.
go ahead, Nicole.
I'm struggling with the recommendation to remove any kind of reference to like having substance use disorder treatment or alcohol treatment or something. I'm kind of afraid that that first question, people are going to miss that that's the meaning of it. So I almost feel like we do need that second question that they recommended removing, or that we add something to the first question that's like including substance use disorder or alcohol treatment, or, you know, something like that. Because I feel like it's going to be missed. And I feel like I get their point about not wanting to discourage people from getting treatment. But at the same time, we work with drugs all day long. So I do feel like this is relevant. I don't know if anyone else is having that struggle, but I didn't love removing that.
Okay, great comment. That's why we have it here. So thank you, Nicole. Trevor?
Yep, I will just second Nicole's remark, especially like as someone in the recovery community. I think the best way to prevent problems is to make sure that everyone is fully aware of that sort of risks that are involved. And I think it can be done in a way that is not discouraging. We want to encourage people that are a part of the recovery community and that have made those positive changes in their lives to feel comfortable in applying, while also acknowledging the very kind of obvious challenges that are there as well. So I would support something that navigates that in that delicate way that again doesn't discourage people that are in recovery, but also makes note of the challenges there.
Thank you, Trevor. Any other member comments? So this is just initiation. So I think we do, if the members are agreeable with the sentiment that Nicole's sharing, which is completely understandable, I think we can, go ahead, Trevor.
So I move to initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1793.65, consistent with the board's discussion, to direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulation at Section 1793.65.
Thank you, Trevor, for the beautifully read motion there. I appreciate that. Today, we're all going to compete for who can talk the fastest. So we're going to then seek for second. Do we have second for that motion?
I can second.
Thank you, KK. So I think that we're all agreeing with the sentiment from our member Barker member Tebow is raised. So I see Maria, your hand is raised. Go ahead, Maria.
Sorry, I just wanted to clarify, maybe with Jennifer and Trevor, that the motion that was in our meeting materials and posted is slightly different, and as long as it meets the needs of what Trevor read, he said, especially the last part, 17.93.65 is what I heard, and it says 0.5. So I just wanted to clarify.
Yes,
I
the motion that Trevor read is more consistent, but I just want to clarify which section. If it's the one that you read from the paper, remember Trevor, then is that one the one?
think, go ahead.
If I could just kind of jump in really fast. So there's two regulations, or there's the next regulation that the board will be considering is 0.65. So I think maybe just pages got stuck together.
Yes,
So
yep.
this section is 1793.5.
Thank you for catching that. Yes.
But it really would just need to amend. Trevor, let's make sure that for the record, you meant to say 1793.5.
For the record, I meant to say 1793.5.
And to confirm that our second, which KK is confirming that.
Yes, please.
Perfect. And members, so are we okay with that direction? Are we all following along? So staff will direct the update to include Nicole's and Trevor's comments and incorporate that and propose a rulemaking. I'm not hearing anybody dissenting, so we're good to go. Okay, we're ready for public comment. In person, please. I don't see anyone, so we're ready for public comment in WebEx.
All right, as a reminder, if you'd like to make a comment, please find that hand icon either at the bottom of your screen through the three dots or the ellipses, or for calling users, press *3. We do have a comment from Chasney Johnson. Chasney, I've sent a request to unmute your microphone.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I was really excited seeing mental health being covered in today's meeting. Being a daughter and granddaughter of nurses whose main focus is mental health, I thought it would be a great time to participate on this topic. Being a patient community, whether that's getting vaccines at your neighborhood pharmacy or being seen by a primary care doctor, I have witnessed, but I wouldn't say it has affected some mind games. For example, pharmacy technicians have taken tests to learn how to administer vaccines. When it's time to get the vaccine, the scheduled pharmacist is asking, which chair would you like to sit in when the seating is already arranged? When being hired at some pharmacies, their onboarding training shows you specific seating arrangements for vaccine rooms. On a health and wellness visit for yourself, you shouldn't have to worry about questions like that when there are standards that should already be in place so a patient can feel safer receiving care from a licensed personnel within a company. Thank you for letting me participate on this topic and have a great day.
Thanks for the comments.
And seeing no additional comments, I'll return the floor to you.
Thank you, Shelley. Okay, members, we're ready for vote. Jesse, how do you vote? Jesse?
Yes.
Oh, there you go. Trevor?
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo. Ricardo.
Yes.
Thank you, Satinder. Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you. And I vote yes. Motion passes. Okay, next agenda item is agenda item 11. Discussion and possible action to initiate another rulemaking to amend California Code of Regulation Title 16, Section 1793.65 related to pharmacy technician certification program approved by the board. Probably some of you, it's like, didn't we just do this? But moving to the next agenda item, as included in the meeting materials, pharmacy law establishes 4 separate pathways to licensure as a pharmacy technician, one of which is certification by a pharmacy technician certifying organization offering an accredited pharmacy technician certification program that is approved by the board. As the statute does not specifically identify the acceptable certification programs, the board has regulations at section 1793.65 that identify the specific pharmacy technician certification programs approved by the board to allow for a required ongoing review of acceptable certification programs and to ensure compliance with requirements included in Basic Business and Professions Code section 139. The regulation section includes a sunset date, which is currently June 30th, 2026. That's why I said this is something we've done 2 years ago because we just pushed that back from 24. So given the recent changes in authorized functions of a pharmacy technicians, efforts are undertaken by the Office of Professional Examination Services, OPES, were delayed. It is anticipated that necessary work will be concluded, however, not in sufficient time for the board to consider audit findings and also pursue a regulation change as necessary. Given this, the board staff is recommending a 1-year extension of the sunset date to ensure completion of a pharmacy technician certification program remains a viable pathway to licensure while the OPES audits are completed and considered by the board. I have reviewed the matter and agree with the staff recommendation, and members, I note that the meeting materials and meeting slide display a possible motion. There it is. Very lengthy motion there. So whoever wants to compete for today's who can speak the fastest, I welcome your comments as well as if anyone wants to make a motion. Members?
All right.
There we go. Thanks, Trevor. Appreciate that.
I move to initiate a rulemaking to amend California Code of Regulations Title 16, Section 1793.65 as proposed. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulation at Section 1793.65.
Thank you, Trevor. Do we have a second? Oh, thank you, KK. Just for the record, KK.
I can second.
Thank you. All right. Do we have any other comments from members? I know this is an easy one, but just in case. Okay, we're ready for public comment. In person. Seeing none, we're ready for public comment in WebEx, Shelley.
All right, if you'd like to make a comment on this motion, please raise your hand. Locate that hand icon at the bottom of your screen. If you're on a mobile device, find the 3 dots or ellipses, and for call-in users, you can dial *3. As a reminder, you will have 3 minutes. Our first comment is from Sean Kim. Sean, I've sent a request to unmute your microphone.
Good morning, board. My name is Sean Kim from California Pharmacists Association. CPHA fully supports the board's proposal to extend the sunset date to approval of pharmacy technician certification program to June 30, 2027. Extending the sunset will allow the board to review the OPES finding to provide time to PTAC, Pharmacy Tech Advisory Committee, to evaluate the changes in context of AB 1503. Ensuring the uninterrupted access to approved certification pathway preserves the workforce continuity and the patient access to the care, and most importantly, their safety. In addition to this proposal, CPHA also recommends that the board to consider pharmacy technicians' continuing education regarding PIC-related responsibility to clarify their roles and responsibility and provide the accountability for both PIC and the pharmacy technicians under AB 1503. Thank you so much.
Thank you for the comments, Dr. Kim.
And seeing no additional questions, I'll return the floor back to you.
Thank you, Shelley. All right. We are now ready for vote, members. Jesse, how do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. The motion passes. Okay, next agenda item is 12, Enforcement and Compounding Committee Report. I will turn the meeting over to our chair, Maria Serpa, chairperson for the Enforcement and Compounding Committee. The floor is yours, Chair Serpa.
Thank you, President O. On behalf of the committee, I'm pleased to provide the board with a summary of the committee's efforts at our October 16th, 2025 meeting. Thank you to my fellow members, Vice Chair Renee Barker, Jeff Hughes, Sung Oh, Ricardo Sanchez, and Nicole Tebow. First item A is summary of presentation on board's outsourcing program. Members, background information on this agenda item is provided in the meeting materials. During the meeting, Dr. J.K. Fujimoto, supervising inspector for the board, provided an overview of the outsourcing program, including board licensure requirements, a comparison of 503A versus 503B facilities, types of drugs compounded, and information on outsourcing inspections conducted by the board. Dr. Fujimoto also spoke about how outsourcing facilities can provide patient-specific prescriptions. Members noted the important role of outsourcing facilities serve for hospitals in providing various compounded products for patients. The committee noted that post-implementation of the outsourcing program, there may be an opportunity for some possible changes to the law that may be appropriate to address at a future committee meeting. Attachment 1 includes a copy of the presentation. Members, do you have any questions or comments on the presentation?
Hi, Maria. Thanks for that. This is Renee. I do want to just encourage anybody who didn't see the presentation, and since the full board is often part of the compounding discussion, it is very enlightening to just to see what the inspectors are doing for California consumers in inspecting these facilities. It's very complex. And I think we, to get their license there, or their out-of-state license. So anyway, I would really encourage people to look through those or listen to the entire presentation. It was excellent, and thank you to the staff who do those inspections.
Any other board comment? Thank you. And as a reminder, we do have some newer members on the board. Committee meetings are recorded and posted, so you can actually watch the presentation in addition to looking at the slides that are in the meeting materials. I think we're ready for public comment in Garden Grove. Anybody there coming forward? I can't see, so someone's gonna.
Sorry, Maria. There's no in person.
Okay. Moderator, we're ready for public comment for people participating via WebEx.
All right, if you'd like to comment, please raise that hand. You should find your raise hand icon at the bottom of your screen. For mobile users, you can find your ellipses to access it, and call-in users can dial *3. And seeing no requests, I'll return the floor.
Great, thank you. Members, unless you have additional comments, we'll move on to the next agenda item. Seeing none, B, summary of presentation on duty to consult and discussion of California Code of Regulations, Title 16, Section 1707.2. Background information on this agenda item is provided in the meeting materials. During the meeting, Deputy Executive Officer Julie Ansell gave a presentation on duty to consult, which focused on the value of consultation, associated regulations, barriers to consultation, and board actions that support patient consultation. The committee discussed if board current regulation requirements remain appropriate and considered barriers that exist to pharmacists providing consultation. Members were concerned that without reimbursement for consultation, it continues to be difficult for pharmacies to prioritize time for consultations. Members also expressed that it may be appropriate to consider whether current regulations might be amended to be less prescriptive and to empower pharmacists to use their professional judgment to determine what a patient needs to know and how they receive the information. Public comment similarly expressed the importance of consultation, that barriers articulated in the presentation are real, and that without proper reimbursement for consultation services, challenges will remain. Attachment 2 includes a copy of the duty to consult presentation. Members, do you have any comments or questions?
I do, Chair Sherpa. I just have, I'll go first. Sorry, I just saw your hand up, Jesse, but, so I think for me, I'm on the committee. So for me, I was lucky enough to voice my asks, but I just want for all the members to hear my 3 asks. So one, I think that it is important for us to consider as the public comment that was submitted for the the written comments that was submitted, as you all saw, if there's a way for us to kind of look at ways for a pharmacy who really is not dispensing directly to patients, white bagging situations, that they would be actually clearly, be exempt from this requirement, because it seems to be a miss. I mean, I think practically, hopefully, we're not doing really anything other than education, but I think it would be nice to make sure the regulations are clear, that it's not applicable, but also ensuring that that doesn't also, there's also oral consultations that we've discussed the barriers and challenges. I think I'm really strongly pushing for, proactive consultations to be explicitly allowed. And a comment Nicole made during the meeting, how understanding that maybe a constant interruption could be a source of medication error, and we must consider that as a factor and hopefully find ways to allow proactive consultation and requiring maybe a documentation for those, and that would be okay in lieu of oral consultation. And as I voiced, I would like us to move forward with a more of a standard of care approach in terms of consultation instead of writing out exactly what must be done. And lastly, I think, our regulation does call out a requirement when a prescription is mailed. I think that's okay, but I would like us to also look more into find ways to improve, not for pharmacies that, mail out one-off prescription and that they're open door pharmacy, but for pharmacies who are closed door pharmacies who primarily mail prescriptions and there's no way for patients to receive medication other than via mail. I want that to be a separate requirement where there may be more of an approach and requirement for them to actually reach out to patients for consultations and discussions. I think that would be my ask. I hope for that to be more of not just a piece of paper, how it is right now. I hope there to be more of engagement, higher engagement for patients via an app, electronic, however ways possible for patients to know that they're right to consultation. So that's my 3 asks.
I can't see everyone, so I see Jesse's hand.
Hi, thank you, Maria. I wanted to speak more about like the barriers to consultation. So number 1, while I agree the consultation requirements need to be a little less restrictive, just from the patient perspective, I think it's really essential that we maintain the consultation requirement. I will say personally, as a patient, I am almost never consulted on new medication, and I'm a pharmacist myself, so I'm okay with that. But that cannot be the standard. And unfortunately, what I see over and over again is that pharmacists are really in over their heads, and the pharmacist isn't even the one screening for the consultation. This happens to me over and over again, unfortunately, and I will say that the pharmacy personnel probably don't realize that I'm on the board of pharmacy or that I'm even a pharmacist. But I think it's really essential that we keep a consultation requirement. And I think there are a lot of barriers to that. I would be curious to see if the consultation violations occur more during flu season, because what we see, at least in the retail chain setting, is that we are being forced to take appointments, and we're being told to prioritize appointments for immunizations over filling medications. And so when you have 15 vaccines in a 15-minute period, it makes it almost impossible to consult the patient. And my fear of being less prescriptive, though, is that you're not really doing a full consultation in that time because you're worried about the next thing. I think there's a lot of factors here that are intricate, but overall, I think just from a patient perspective, we really need to make sure the core of consultation is preserved moving forward.
Thank you. Any other member comment before we go to public comment?
Yes, Chairperson Maria. There has been many there are many nuances in mail order and pharmacies that deliver prescriptions to the patient, like patients in ALF and independent living settings. And I think there are a little bit of I think the presentation slide number 34 very adequately describes what they are. And that system, in my opinion, works fairly well. As far as retail is concerned, there have been many technological advances that has happened in how prescriptions are screened or not screened. So it may not be a bad idea to learn also from the industry that what kind of measures that industry has taken and put in to screen for patients who definitely needs more consultation than people who are taking the repeat medications or refills. So I think it'll be a good idea in the future, if possible, to take some input from industry as well.
Thank you. I think that's an excellent idea. This was our first formal step into this area we've talked about over the years. And so we're looking at having an ongoing discussion in the committee to address this topic more formally. Oh, I'm sorry, Nicole, I didn't see your hand.
Oh, I just raised it. Thank you. This was mentioned already, but I'm just emphasizing it as well, that I think there needs to be some kind of exemption for drugs that are filled by a pharmacy but going to be administered in a clinic. We're seeing more and more of those with like long-acting injectable drugs around the consultation requirement. You can kind of treat it like a delivered or mail prescription, but it's otherwise very awkward, and you often don't actually get to interact with the patient in any way in those settings. So
Yes, thank you. And I wanted to acknowledge we did receive written comment on that specific topic. We talked about it during the committee, and everyone should have had the letter that came last week that reiterated that. That was Nicole's comment during the committee meeting also. Any other member comment?
I was going to make, Maria, one comment, short, but most of it has been said already. I agree that we should make it a clarification in specific setting where it's being prescription is dispensed to the provider, and the consultation requirement may not be the same in that scenario. And I agree the requirements needs to be there for consultation, but I propose as we move towards standard of care, I agree with the concept that it doesn't need to be prescriptive, because sometimes when you engage a patient, you realize they may know many of the steps that are already in the consultation. Then it could be more interactive and allows the flexibility of the pharmacist to assess what needs is important to be for the patient to know versus what they already know. That's all.
Thank you. Any others, or are we ready for public comment? I can't see Sung anymore.
Sorry. Yes, members are good, I think, and we're ready for public comment in person.
Any public comment in Garden Grove in person?
Yes, we do.
Good morning. Mic on. Good morning, board members. Lori Walmsley on behalf of Walgreens. I didn't have the opportunity to participate in the committee, but I certainly do appreciate this conversation. I think many of you know I serve on the Arizona Board of Pharmacy, not speaking on behalf of my board, but we're having very similar conversations. The environment certainly has changed, and patient expectations have changed. One of the things that my board has talked about is potentially changing our rules to allow for a pharmacy technician to make the offer to counsel and then also accept a decline, just because of some of the workflow pieces that occur. Oftentimes, when you're working in a pharmacy, a patient, the technician will say to a patient, the pharmacist will be able to consult with you with your consult with you about your medication, and the patient will say, I don't want to talk to the pharmacist. And that immediately puts a hold on the workflow. And that's one of the reasons why we've started talking about it, but really appreciate the conversation. I like the idea of allowing proactive consultation and look forward to the additional discussions on this.
Thanks for the comments, Lori. We have one more, Maria. Sorry, I keep thinking that you have camera angle from that side, and so I'm keep thinking we're in Sacramento room, so I apologize. I'm gonna do my do better about providing what's going on in this room. I'm sorry, Maria.
No, you're
Go
fine.
ahead.
Hello, board members. My name is Vincent Chires. I was not expected to comment on this, but since I am here, I do agree that maybe there should be some discretion with future technology in terms of consultation. However, at the retail setting, I'm a little bit more cautious. Already using the CVS app, you can activate your prescription. It will actually ask you, the patient, to clarify if your drug dosage has changed. And unfortunately, the app is still being used. There still needs to be additional safeguards because patients are still adapting, especially my older patients. So they're just clicking the blue button to get through so they can do a mobile app pickup to pick up their medication, not necessarily reading the warnings. So I will just express caution and when we talk about this subject further in the retail side. Thank you.
Thank you for the comments. I think that's it for the room, Maria. Go ahead.
Great. Thank you. Moderator, we're ready for public comment for people participating via WebEx.
All right, we have a few with hand raises already. It's just a reminder, if you'd like to comment, please raise your hand by locating that hand icon at the bottom of your screen. For mobile users, you can locate the ellipses, or for calling users, dial *3. And our first comment comes from Paige Talley. Paige, I've sent a request to unmute your microphone. All right, I'll circle back. Let's move on to, and I apologize for butchering the pronunciation of your name, Afruz Nikmanesh. I've sent you a request to unmute. You will need to click the unmute me button when it pops up on your end. Right.
Hear me?
Yes, we can hear you.
Oh, good morning. You did an excellent job on the pronunciation of my name.
Oh, great.
Shocking. Good morning, everyone, board members. I apologize. My connection is a little bit spotty, so I apologize if this has been talked about or addressed. As far as consultation is concerned, as somebody who's worked in retail for the last 28 years, and I've seen the evolvement, unfortunately, in the retail industry, I think it might be a good, nowadays we allow technicians to do a lot, including immunization. And I think that maybe incorporating, allowing them to ask the patient if they have, they can just, maybe present the medication to the patient and not just showing it to them. Something to the effect of asking the patient if they have taken the medication before, if they have any questions. Because what the requirement is right now makes it extremely impractical. And in the flow of the pharmacy, unfortunately, with most pharmacists, being under a lot of pressure and being understaffed, it basically creates more, I hate to say this, but more opportunities for mistakes to happen, or, taking the pharmacist away from matters that only a pharmacist can do. While a technician can simply ask a question, or a clerk can ask the question. It also creates a lot of frustration among patients, because they want to take their medication. I don't want to speak to the pharmacist, but the pharmacist is not available, so they have to wait there. The clerk cannot give out the medication. It creates a lot of unnecessary, in my opinion, work and frustration. So I respectfully ask the board, maybe you can consider, incorporating that, a clerk or a technician can simply ask the patient if they've taken the medication before, if they have any questions, and kind of get them involved in their in participating in, what their medication is, what, changes have occurred. So that's all I had to say. Thank you for allowing me to speak.
Thank you. And we have a call-in user. Your number ends in 17. You've raised your hand. I'm sending a request to unmute your microphone.
Hi, good morning. This is John Gray. Can you hear me?
We can hear you.
Oh, great. Thanks. So this is John Gray, registered pharmacist with Kaiser Permanente. So thanks for the opportunity to comment. Just a couple observations on this discussion. First of all, we fully agree with the board members' view. Many board members' view expressed related to the importance of consultation. Pharmacists are among the most accessible healthcare providers available to patients, and consultation is an excellent way for patients to access their pharmacist to make sure that they understand how to take their medications properly. I think on the discussion of whether there ought to be a forcing function, my words, for consultation by mail order pharmacies, I would urge the board to be cautious about that and consider whether requiring consultation, requiring an individual to engage in consultation is overly paternalistic, right? I think individuals have agency and should be able to make decisions about when and how they engage with healthcare professionals. So it would encourage the board to think about that. And then lastly, on the question of, whether the regulation ought to be tailored to free up the pharmacist to select what ought to be discussed during a particular consultation. I think that's a great thing to pursue. I would also, I think, ask the board staff to look at whether the changes to Business and Professions Code Section 4051 under AB 1503 kind of already has already applied a standard of care to consultation, right? In my reading of the statute, the elements that the pharmacist needs to provide consistent with the accepted standard of care include providing clinical advice or patient consultation. And so it may already be that that a pharmacist standard of care would be the driving factor in what should be addressed during a consultation. And so perhaps the regulation is absolutely in need of update. Thank you very much for the opportunity to comment.
Thank you. Next comment comes from Sean Kim. And before I unmute your microphone, Paige Talley, I'm going to circle back around to you. If you still wanted to make a comment, please raise your hand again so that I know. Okay, I will come back to you after Sean. Sean, sending the request to unmute.
Good morning, board. I'm Sean Kim from California Pharmacists Association. We appreciate board's continued discussion of duty to consult and its real-world barriers. The presentation at the last board meeting was well delivered and very informative. Pharmacist consultation is one of the most effective tools to prevent med error, improve adherence, and most importantly, is building the relationship that we have with the patients and consumers. Yet without appropriate and dedicated reimbursement, pharmacies struggle to consistently allocate the time and the resource required to meet this expectation. Advancing this work will require continued engagement with DHCS and commercial payers. It has to become with the payers conversation that the existing statutes that we already have in California, such as SB 493 and AB 1114 and AB 317 lately. So to reliably meet the duty to consult, pharmacy needs, first, they need the appropriate reimbursement for consultation for the time. And then number two is bidirectional health information technology to document the care and access the accurate patient information. Without having the accurate patient data, shared decision-making model cannot be achieved, and it increases much more administrative burden. Essence to these supports, consultation risk becoming a check-the-box operational task that may inadvertently increase the risk of consumer harm. CPHA also applauds the board movements towards the standard care model through AB 1503, which we'll discuss further later today's meeting, which that standard care spirit really provides the professional judgment and determination of when and how the consultation should occur and whether rather than relying on to prescriptive language to require them to do so. So CPHA looks forward to collaborate with the Board of Pharmacy and stakeholders to modernize the regulation, and consultation remains both clinically impactful and operationally feasible. Thank you so much.
Thank you.
And circling back to Paige Talley. Paige, I've sent a request to unmute your microphone. All right, Paige seems to be having some issues unmuting her microphone. President O, would you like me to open the chat for her to submit her comments?
I'll defer that to our chair, Serpa, but I think if she can connect later, we could just allow her to speak later.
Okay.
That sounds fine. I still have many items on my presentation, and if she does connect at some point, we could add that for comments.
I will keep working on that with her. And with that, I will turn the floor back over to you, Chair Serpa.
Thank you. Members, you can see that this is a very dynamic and diverse topic. Even though it appears to be on only one issue, it actually is a continuum of issues. The committee will continue to discuss it and keep the board informed. With that in mind, members, do you have any additional comments before we go on to the next comment or the next agenda item?
I am, hi, Member Serpa. I just want to say that I will be stepping out in 4 minutes and will be returning shortly.
Okay, the next item does have a
And-
vote, so you might not be able to vote on it.
And Maria, I
okay.
see Jessie and Claudia had her hands raised, so I'm not sure
Okay,
if they meant
thank
to or
you.
not, but
Let's go with Jesse. I can't see you guys, sorry.
Oh, that's okay. Thank you, Maria. I just wanted to follow up on a couple comments made. Just for the record, I don't agree with the idea of a technician screening for consultation. I've had several technicians throughout my career, countless times in which they have supposedly screened a patient for me, claiming that a medication was a refill when it wasn't, when I actually review the patient profile. And until there's more autonomy in the law that removes the responsibility from the pharmacist, if that were to happen, at this time, I don't think that's a good idea, unfortunately. I definitely agree with the concepts, as I said before, that there needs to be some less prescriptive requirements for consultation, and especially in certain settings, but especially in retail when we're talking about changes where it may be a doctor that's changed or the directions that have changed. But wanted to just note those two things for the record. Thank you, Maria.
Thank you, Jesse. And Claudia, was that you who had your hand up?
Yeah, I just want to say thank you for all the people that are there and who gave their public opinion. I think that's good information and things that we will consider as a board. So please keep showing up.
And just to add one more thing, Maria, sorry, I think a good example of a situation, as we all know, is the GLP-1s, right? So people are getting on 2.5 to start like a Zepbound, but then like next month they're going to 5. And it's a great opportunity to do the consultation to confirm the dosage. But all the requirements in our regulation, it really is not a practical thing. It's great for pharmacists to provide that consultation, but just not in the sense of how it's written in our consultation reg, in a sense that just confirming the dose and making sure they know how to use it. It's a great opportunity to just double check the patients on top of it. But when you go up to 2.55, 7.5, 10, right, every dose increase would require technically our consultation, right? And that would technically require our consultation requirement to be fully compliant with our law. But I think in practical sense of standard of care approach, is that really necessary? That's the question. And I hope that we move forward with a better approach. Thank you.
Thank you. Any further comments before we move on to the next agenda item? Okay, so I think that means none. C, summary of discussion on hospital pharmacies and Business and Professions Code 4113.1, medication error reporting, include possible action to initiate rulemaking to amend California Code of Regulations, Title 16, 1710. Members' background information on this agenda item is provided in the meeting materials. As you may recall, the board refers to the medication error reporting under Business and Professions Code 4113.1 as the California Medication Error CAMER program. Subdivision C of section 4113.1 defines community pharmacy for the purposes of this section to include any pharmacy that dispenses medications to an outpatient. Existing regulation, California Code of Regulations, Title 16, 1710 establishes the conditions and sets volume limits under which a hospital pharmacy may furnish drugs to outpatients, employees, or walk-in customers. The committee agreed that the board has previously expressed its policy and intent that the CAMER reporting would not require hospital pharmacies to register. There are existing requirements that already apply to hospitals under the Health and Safety Code, including requirements to report adverse events and to adopt a formal plan to eliminate or substantially reduce medication-related errors. The board received comments during the previous committee and board meetings asking for clarity on whether hospital pharmacies are required to register and to report to CAMER. During the October committee meeting, the committee considered a possible change to the regulatory text in 1710 to provide further clarity to the board's regulated public that the term community pharmacy, as defined in 4113.1, does not include hospital pharmacies operating consistent with subdivision A of 1710. I'm sorry, there's a lot of references here, but that's important because it has caused a little bit of confusion. So during the meeting, the committee discussed this issue, and there's a general consensus that the language is representative of the board's policy in agreement to refer draft language to the full board. So because of the confusion, we are making this suggestion for this minor adjustment to the regulations to put in the regulation what our previous intent and discussions have been at previous meetings. In addition, the committee members expressed an interest in board staff learning more about hospitals dispensing prescriptions to outpatients to understand better what this represents. Attachment 3 includes a copy of the proposed regulation. As we begin member comments, should the board believe proposed language is appropriate, a possible motion to formally initiate rulemaking is included in the materials and displayed on the next slide. Oh my goodness, get your glasses out. Members, any comments? And I would appreciate a motion. I can't
Maria,
see.
this is Renee. I just wanted to say that it was a great discussion that we had there regarding this. And I do believe that this would be a good clarification to really avoid the confusion that exists currently for hospitals.
Thank you. Would you like to make a motion, Renee?
Yes. Anybody else have a comment before? No.
We'll still take comments after too.
Okay. And then is the text in that screen that's far, far away? Is it the same that's in our materials? Okay, so I shall be reading that then. Okay. So I'd like to make a motion to initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1710, as proposed. and authorize the executive officer to further refine the language consistent with the board's discussion. Direct staff to submit the text to the director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 40-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulation at section 1710.
I second that. This is
Thank
Song.
you. Thank you both. With a motion and second on the floor, members, do you have
So-
any comments or questions before?
So sorry to interrupt. I just wanted to make sure that it's going to be a 45-day comment
45
period.
days. Yes, I'm sure that's what Renee
That's
meant.
part of the motion.
Renee, if you could just. confirm.
Yes, that's in the language. If during the 45-day comment period, they don't receive any comments.
Yes, thank you.
Okay, thank you.
Hey, members, I can't see everybody, so do you have any comments or questions on the proposed regulatory change?
I don't have
On
any
the
member
motion.
comments.
No member comments? Okay, let's begin with public comment for those in Garden Grove.
Nobody seems to be eager to come up here yet, so I'm gonna say that as a no. Chair Serpa.
Thank you. We're ready for public comment for individuals participating via WebEx.
All right, as a reminder, if you'd like to comment, please raise your hand. You can locate the hand icon at the bottom of your screen. If you're on a mobile device, locate that ellipses to access the hand raise feature. And for call-in users, you can dial *3. I will call on you by name, and when I let you know I've sent you a request to unmute your microphone, you will need to click on the Unmute Me button at your end to thereby unmute. Our first comment comes from Kathy Gomishi. I've sent you a request to unmute your microphone.
Hello, good morning. Thank you for the opportunity to comment. I am grateful to the board for revisiting this very important topic. I am a medication safety officer at an academic medical center that's part of a large system, and we've been working very hard to meet the intent of this regulation to promote a culture of safety, promote error reporting, learn from those lessons that we identify from the nature of error reporting, and make improvements to our health system practice. I will say that there's been a lot of gray area in determining which of our pharmacies and which of our patients this regulation is applicable to. And as we already participate in error reporting and sharing our data with a designated patient safety organization, we want to meet the intent and the letter of the regulation. So thank you for the opportunity to clear up some gray areas. This might include, but is not an all-inclusive list, but areas such as infusion centers, patients receiving medications at infusion centers, patients who are receiving medications from investigational drug services. So thank you for the opportunity to provide further comment to help clarify from the health system perspective which of the pharmacies and patients this will be applicable to.
Thank you.
All right, and our next request comes from our calling user, number ending in 17. Sent a request to unmute your microphone. I see you are unmuted. We are not able to hear
Sorry.
you.
Yep.
Oh, there you go.
I had myself double muted. Sorry about that. This is John Gray, registered pharmacist of Kaiser Permanente. Just wanted to express our support for the proposed modification to the regulation. We think this will provide the clarity that our hospital pharmacists are looking for. Thank you very much for the opportunity to comment.
Thank you.
And that was our last request for comment. Turn the floor back over to you, Chair Serpa.
Thank you. Members, any final comments before we go to the vote?
No comments here.
Seeing none, I turn the meeting over to you, President O, for the vote.
Thank you, Chair Serpa. Jesse, how do you vote?
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole. Nicole? Nicole is frozen on my screen. Okay, I think we'll just have her be no voting, but
There she is. Nicole, you keep going.
Sorry,
Unmute.
sorry.
There you go.
I don't know if you heard me. I said yes. There was some
okay.
internet connectivity issues, but it's
Thank you,
back now.
Nicole. Thank you, and I vote yes. Back to you, Chair Serpa.
Thank you. Moving on to D, summary of discussion on frequently asked questions related to Assembly Bill 1286, including possible action to approve proposed updates to FAQs. The background information on this agenda item is provided in the meeting materials. Attachment 4 includes a copy of the updated FAQs. You will note that the committee is offering a recommendation to approve the proposed updates to the FAQs, including additional updates made after the committee's discussion to reflect changes on the board's sunset bill, AB 1503. With the committee's recommendation serving as the motion, members, do you have any questions or comments on the updated FAQs?
I don't see any member comments here.
I know we've reviewed these FAQs. I do appreciate staff and the committee's constant updates because this is an area that people are asking a lot of questions about. Seeing no member comments, is there public discussion in Garden Grove?
Don't see anybody coming up to the microphone, so nope.
Okay. Moderator, we're ready for public comment for people participating via WebEx.
All right, we are looking for anybody who would like to comment on this item on WebEx. Again, you'll need to raise your hand so that we can see your request. Locate that hand icon or dial *3 if you are on a phone. And seeing none, I'll return the floor to, oh, stand by. We have one request from Kathy Gomishi. Kathy, sending you the request to unmute.
Hello, thank you for the opportunity to speak on this topic. I would be appreciative of the board being able to revise the frequently asked questions section for Assembly Bill 1286 to help promote better clarity, particularly for the CAMR med error reporting program. And if this also pertains to the previous topic, just any feedback that is received to help sites have a clear understanding of how best to be compliant with these regulations. Thank you.
Thank you, Dr. Gomeshi. I think there are 2 questions in there, but we certainly at the next committee meeting can look at the one that talks about infusion centers, which I think was your area. It may be able to be edited for the next version. Any other public comment?
That's the only one, so I will return the floor back to you.
Thank you. Members, any further discussion before we go on to the vote?
Don't see any.
Okay, President O, I've turned the meeting over to you for the vote.
Thank you, Chair Serpa. Jesse, how do you vote?
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, Jeff is not here. KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Just for planning purposes, we're gonna probably take a break at like 10:30-ish. So if that works. So we'll turn it back to you, Chair Serpa.
Thank you. Before moving on to E, I just wanted to ask Shelley if she got a hold of Paige Talley. There's an opportunity to speak here or after E.
I'm gonna cue her up again and see if she can unmute. Paige, I've sent the request to unmute.
Okay. Sorry for there's a little bit of unfortunate circumstances. Thank you. We're now down to 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6. Okay, so we're probably gonna have to take a break. We're gonna have to take a break, Chair Serpa. We're gonna take 15-minute break and we'll come back at 10:30. I'm so
Okay.
sorry.
That's not a problem. I don't think there are any more votes in my report, just for your information. Okay.
Okay. All right. We'll take a break. We'll come back at 10:30, everyone. Thanks, Trevor. You know, I'm not a gavel type of a person, so we're ready to get back on it. So we'll take a quick roll call. Jesse, are you? Thank you, Cisco. Jesse, are you back? I don't see her on my screen, but she might not be back. I'll move to Trevor.
Present.
Thank you, Renee.
Present.
Thank you, Jeanette.
Present.
Thank you, KK.
Present.
Thank you, Claudia.
Present.
Thank you, Jay.
Present.
Thank you, Ricardo.
Present.
Thank you, Satinder.
Present.
Thank you, Maria.
Present.
Thank you, Nicole.
Present.
Thank you, Jesse. We do thankfully
Okay.
up there.
Hello, I'm here. Sorry about that.
That's okay, Jesse. Thank you. And I'm here. All right, Chair Serpa, back to you.
Thank you. Before moving on to agenda item E, I just wanted to circle back regarding the public comment on A from Paige Talley. Has she been?
I'm going to try her again. I did have to log out and back in because I was having some technical issues at my end, so I want to make sure it wasn't as a result of that. Paige, I have sent you a request to unmute your microphone. You should see an unmute me button at your end. I've also sent Paige a chat to let her know that if she's having issues, we can find an alternative. And I'm not seeing any response out of her microphone, so I'll just keep an eye on the chat to see if she responds back to me that way.
Great, thank you.
You're welcome.
Moving on to agenda item E, summary and discussion of recently signed legislation impacting the practice of pharmacy, including possible discussion and action on proposed implementation activities. Members, as we do at our fall meeting each year, the committee discussed enrolled legislation that was either signed or vetoed by the governor. Note, measures that were vetoed by the governor are not included in this report. The first measure for our discussion is Assembly Bill 82 regarding legally protected healthcare activity, which expands the address confidentiality program to a gender-affirming healthcare provider, employee, or volunteer who faces threats of violence or harassment from the public because of their affiliation with a gender-affirming healthcare service facility. The bill also prohibits a prescription for or the dispensing of testosterone or mifepristone from being reported to the Department of Justice, Cures, or a contractor as specified. The committee noted agreement with the implementation activities offered by staff. Members, do you have any comments on AB 82?
We have one.
I'd just like to state how proud I am that the Board of Pharmacy stood with this legislation and supported it and during these particular. Just want to say how proud I am to be a part of a board that supported this legislation in these very tense times to protect gender affirming care as well as reproductive health access.
Thank you. Any other members?
This is Nicole. I'll add on to what Trevor said and say it's so important that we're doing this. Just last week, the federal administration came out and released plans that they are going to, one, not pay for any gender affirming care for youth in Medicaid, but potentially also not make any payments to anyone that provides gender affirming care to youth through Medicaid. So you'll essentially be cut off from Medicaid and Medicare if you provide these services, which is not consistent with California law, this adding to that. So it's going to have to be a legal battle here in California, but I'm glad to see that we are standing with the trans community.
Thank you. Any other member comment before we go to public comment? Okay, any public comment in Garden Grove?
I don't think so, Chair Serpa.
Okay, moderator, we're ready for public comment for individuals participating via WebEx.
All right, if you'd like to make a comment, please raise your hand. You can find that hand icon button at the bottom of your WebEx screen. For mobile users, you can find the ellipses or 3 dots to access the icon. And for our call-in users, you can dial *3. And not seeing any requests. Here we go. Sean Kim, you are up, and I've sent you the request to unmute your microphone.
Thank you, Board. CPHA also supports the Board's implementation for AB 260 to ensure sustainable access to the medication, abortion, and gender-affirming care. We've been collaborating with the birth control pharmacist, and we also seek for help with the CDPH for continuing of the care for Californians. So thank you so much, and we applaud your efforts on AB 260.
Thank you. I think that's going to be coming up soon, but they're very similar, or there are some similarities in the bills.
And seeing no other requests for comment, I'll return the floor to you, Chair Serpa.
Thank you. Our next measure for discussion is AB 144, which authorizes pharmacists to independently initiate and administer immunizations that, as of January 1st, 2025, had a federal ACIP recommendation or are recommended by the California Department of Public Health. The committee noted agreement with the implementation activities offered by staff. Members, do you have any comments on AB 144?
Don't believe so here. Jesse's hand is raised, Maria.
Thank you,
Right,
Jesse.
Thank you. I just wanted to note for this measure too, how important it was. And I just appreciate that California was so on top of this. I don't know if anyone else had a chance to watch some of those ACIP meetings, but it was quite a nightmare. And so I'm just very grateful that our consumers in California are going to have access to immunizations if they choose to access them. Thank you.
Thank you.
This is Renee. I also wanted to comment just to say that I also, in terms of consumer protection, this is a really important step to provide the public with consistent messaging about the vaccines based on actual science and for their health and welfare. So it's just really great legislation.
Any other comment? I would like to add my thanks to board leadership and staff for notifying licensees of their additional opportunities to continue to provide vaccines, because it was confusing if their only resource was the media. And so I appreciate the board getting out the information to licensees about what was legally authorized. Any other board members? Okay, public comment in Garden Grove.
We don't have any.
Thank you. Moderator, we're ready for public comment via WebEx.
All right, again, raise your hand if you'd like to make a comment on this item. We are displaying instructions for your use. For call-in users, you can dial *3. Our first comment comes from Sean Kim. And before I unmute his button, I did receive an email from Paige with her comment whenever you are ready to receive that. So Sean, I'm sending you a request to unmute your microphone.
Thank you again. I apologize. I was ahead of myself and comment about AB 260 confused myself. But this is for AB 144. So we appreciate the board's communication on AB 144, which authorized pharmacists to independently initiate and administer under ACIP recommendation, which was approved before January 2025, and CDPHA recommendation for individuals 3 years of age or older, effective in September 17, 2025. So this really helps the gap of the care for the California pharmacists to provide immunization, both federally and state immunization recommendation. CPHA respectfully notes, however, that the board's recent alert on the webpage updated information on pharmacists' authority to administer vaccines, specifically for the statement that Business BMP Code Section 4052A11 currently provides the pharmacist with authority to administer immunization to any person, regardless of age, pursuant to protocol with a prescriber. So this statement has created some confusion amongst some licensees. The statement may be interpreted as suggesting that pharmacists have independent immunization authority does not take effective until January 1st, 2026 under AB 1503. Even though that it was addressed that AB 144 provides the independent authority to the patients 3 years and older, beginning of September 17, which is addressed on the bottom of the page. But then, since that 1503 statement was on the top of this web page, so it could also potentially create some confusion. So to avoid this misinterpretations, CPHA recommends the boards to clarify the update outlining the relationship between the overlapping authorities of AB 144, which is effective since September 17, 2025, and AB 1503, which is effective in January 1st, 2026, that allows pharmacists to immunization authority under the standard of care model. And CPHA supports the board's education outreach efforts and stand ready to collaborate on clear implementation of materials to ensure consumer safety. Thank you so much for letting me comment.
Thank you, Dr. Kim. I appreciate your comments. I'm sure board staff have heard your comments and will look at future alerts that are sent out to with that in mind. Any other?
That is our last comment for this item.
Thank you. And then Shelley, also for Paige, we'll take her comments on item A after we finish this agenda item.
Sounds good.
Okay. Okay, next measure for discussion is AB 260, which authorizes pharmacists to dispense medication abortion drugs such as mifepristone without including patient name, the prescriber's name, or pharmacy identifying information on the label. It also provides legal protections for pharmacists, protecting them from criminal or civil liability and professional discipline when dispensing these medications in compliance with California law. Members note the importance of legislation to maintain access to reproductive health care and agreed with staff recommended implementation activities. Members, do you have any comments on AB 260? Jessie.
Hi, thank you, Maria. My one comment, and it says that no public comment had been received, but I'm curious if anyone is familiar with the software systems and whether or not they would actually allow excluding a patient's name on label. That was the only thing that I noted, just personally, but I'm full support of this. I think it's a great piece of legislation and just another testament to the good work that California is doing right now for its consumers.
Thank you. Any other member comments?
Nicole has her hand raised, Chair Serpa.
Thank you, Nicole. I couldn't see you.
Hi, Jesse. I was just going to respond to you to say that there's often workarounds. It's kind of like what you do when you're doing like a sexual health STI treatment for a partner where you don't necessarily have their name. So you can create the label through like almost like a dummy profile. But this is where it gets tricky, that the drug may not necessarily appear on that person's profile later. So there are workarounds, but what the record looks like after the fact can be a little tricky. I'd also flag, speaking to the piece about software, is that some software links to other states. Obviously, we know that with big chain pharmacies, but also things like Epic, which is very commonly used, is a shared profile. So if your patient goes out of state, it may be able to be seen somewhere else if this is in that profile. So that's why this is so important.
Thank you. Any other comments from members?
Claudia also has her hand raised, Chair Serpa.
Thank you, Claudia.
Thank you. I wanted to follow up with Nicole. So from what you just mentioned, just to clarify, will the physicians in the next, let's say, patient visit, will they be able to tell if they took this medication?
It depends on how they end up using this law. And that's part of why it exists. So if you do it without labeling, they may not be able to see, depending on your software and how you label it. And part of the concern for that is that if it did show up and the patient went to another state where this wasn't allowed, abortion, things like that, that other state might be able to see it and try to take action on your patient, if that makes sense.
Yeah, so in terms of physicians providing standard of care and potentially noticing side effects or things that might have gone wrong with the particular patient after they took this medication, we wouldn't be able to, I guess there's going to be somebody's going to be blindsided because all the data is not being shared, which is a good thing, but it's also potentially can harm the public because there's no data on what they consumed. That's what I'm hearing.
I think the idea, part of it being that the patient could provide the information. And again, this isn't the first time that the first situation in which this exists. So we've seen it before in other cases. It'll be a rare scenario, and it's a risk versus benefit, balance.
Right. Okay. Well, thank you for that, Nicole. I appreciate it.
Jessie also has her hand raised. Maria?
Thank you so much, Nicole. That's very helpful. So then I don't know if this is directly to Nicole. I won't direct it to you, but I guess the other piece that I have a question about is the prescriber's name not being on the label. I know particularly with my software or the ones that I've used in the past, you usually can't enter a prescriber without having at least some piece of information, whether it's a license number or an NPI or DEA or something like that. And so I'm curious if we've had anything like this in the past, and if we think this may be a barrier for pharmacies to be able to implement.
Those are all good questions. Operationally, I think every organization may have a different answer. That's very common with laws, is it doesn't tell you how to operationalize it. But those are all good questions. Any other member comment? Okay, we're ready for public comment in Garden Grove.
No public comment, Chair Serpa.
Okay, moderator, we're ready for public comment via WebEx. Okay, for our attendees on WebEx, if you'd like to comment, please locate that hand icon. Raise your hand. Our first comment's going to be coming from John Gray. John, I've sent you the request to unmute your microphone.
Hello, good morning. This is John Gray, registered pharmacist with Kaiser Permanente. Just want to respond directly to Board Member Crowley's question about, organizations and their pharmacy information systems' ability to omit certain information from the prescription label, like patient name, prescriber name, etc. Our preliminary analysis of Kaiser Permanente is that our system cannot currently support that function of omitting information from a prescription label. Kind of the level of effort and level of expense that would be required to modify our information system to do that is something that we're currently exploring. But I anticipate it would be a slow and expensive process if we decide to move forward with those changes. Thanks for the opportunity to comment.
Thank you.
And not seeing any other requests for comment, I return the floor to you.
Thank you. Members, any additional comments before we move on?
Maria, sorry, this is Corinne. I just wanted to chime in just for members' clarification to make sure that people know that the way the law is written, it's not a mandate. It's a pharmacist may at their discretion.
Thank you. I don't think that was quite understood. Members, any further comments before we move on? Okay, the next measure for discussion is AB 309, makes permanent the allowance for pharmacists to furnish hypodermic needles and syringes to persons over 18 without a prescription or permit. Additionally, the measure makes permanent the requirement for pharmacies that furnish non-prescriptive hypodermic needles or syringes to provide written or verbal counseling to consumers at the time of furnishing or selling. Members noted agreement with the implementation activities recommended by staff. Committee members did. Members, do you have any comments or questions about the implementation activities for AB 309?
Chair Serpa, I just have one comment about this bill, which is great. I'm happy that this is the sunset is struck out of the bill, but I also would like to just add, since we're talking about AB 1503 later and that it's not agendized, friendly reminder that it's changed to now allow pharmacists to initiate and furnish all basically test strips, lancets, any medical devices. So I think that that would allow pharmacists to be able to use their authority to dispense such devices as hypodermic needles and syringes via their own prescribing authority.
Thank you for that additional information. Any other member comments? I can't see everybody, so any comment in Garden Grove from public?
Seeing none?
Thank you. We're ready for public comment via WebEx. Moderator?
Anyone would like on WebEx would like to comment on this bill, please raise your hand. For calling users, you can dial *3. Our first comment comes from Chasney Johnson. Chasney, I've sent the request to unmute.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I would just like to make a comment about the needles being purchased, even if it's at 18 years or older. There's a lot of retail stores that are surrounded by schools. We know like teenagers can look older than what they are. So it would be cool to just, I don't know, like even working at Target, sometimes it would be nice to like have a picture ID, just so it even says age 21 by certain age. So you can kind of calculate how old they are, or if it was a function on the cash register where you can type in their first and last name, just to have like a security function so it's not like somebody's just walking in here buying needles for fun. We want to make sure it still is like a safety measure, but that would be my comment for this agenda item. Thank you.
Thank you.
And seeing no other requests, I'll return the floor to you.
Thank you. Members, any other further comments on this item? Okay, moving on. The next.
Hi, Maria. Sorry, it's Nicole. If I could make a comment.
Sure.
I just kind of expanding on the commenter that was just speaking. I know when I worked in retail, there was a lot of hesitation on providing needles to people. For some reason, people really wanted to make sure. And, I just want to remind everyone that the reason that we provide clean needles is because it's a harm reduction measure. There's almost never harm in giving someone clean needles. If someone needs needles, you want them to have clean needles. So, as much, we definitely want to be safe and we definitely want to follow the law, but you are almost never, I can't think of any scenario when you're harming someone by providing clean needles. So just putting that out there.
Thank you, Nicole. Any other comments?
Hi, Maria. This is Jessie. I will say I have worked at pharmacies in which we've dispensed needles to patients without prescriptions, and they use in the parking lot and then leave needles out. And so in that sense, it is a harm to the community if they're not disposing of it properly. Unfortunately, a lot of the safety containers can be expensive. Sometimes it's like $30, unfortunately. And realistically, people may not be able to afford that. So moving forward in the future, I would love to see a way in which we could be able to give people clean needles, but also give people affordable or free options for safety containers as well, so that we kind of address both concerns.
Thank you. Any other comments?
This is Claudia. I wanted to follow up with what Nicole was saying. So as of now, if somebody wants to buy needles and there's no prescription, the pharmacist doesn't have to log in their information. So it's just like literally a retail sale, goods for services and goods for cash, and that's it.
This has been the law for a while. This is just making it permanent so it doesn't sunset. We can sell without clean hypodermic needles without a prescription.
Right, but so there will be no record of that person buying. I just want to clarify that for myself.
Right.
Correct. Okay, thank you so much.
Thank you. Any further comment?
Oh, we actually have an in-person comment, I think. Yep, okay. Thank you, Dr. Dang. Thanks for breaking the chain. Yay.
Hi, Richard Dang speaking on behalf of myself. I think it was Jesse's comment earlier. There are some local resources from counties, cities, and the state that offer free sharps containers to individuals that can be requested. So that can be a great resource that pharmacies and pharmacists can provide to their patients when they're providing these hypodermic needles. Thank you.
Thank you. I'm glad you mentioned that, Dr. Dang, because I know in my county, Sacramento County, free sharps containers are available on request. Not from pharmacies, but from waste management. So since we had additional public comment, I think we need to ask members again if they have any comments. Okay, seeing none. I'm sorry, Dr. O, what did you say?
Oh, sorry, I was just letting you know we do not.
Okay, thank you. Our next measure for discussion is AB 447, which allows prescribers to dispense the unused portion of a dangerous drug as defined, excluding controlled substances that the hospital acquired to an emergency room patient upon discharge, provided it is necessary to continue treatment. As noted in the meeting materials, there are details regarding the medication limitation and labeling requirements. This measure also exempts certain automated unit dose systems from licensure requirements when used to dispense drugs to emergency room patients. This committee agreed with the implementation activities recommended by staff. Members, do you have any comments on AB 447?
Hi, Maria, this is Renee. I do, and I'm asking as somebody who's only ever worked in a hospital setting, and I don't do much with outpatient prescriptions. So, but when I see this and the labeling of these, is this considered then an outpatient prescription? It simply is labeling, and it's the hospital order that it counts towards?
So currently, many hospitals do have a way to label medications for patients to take home, either as a discharge or a relabel, like for an inhaler. So it is, maybe staff can respond to it, but in my experience, it does have a separate prescription number, so it's an outpatient. But
sorry, so
maybe staff
is an outpatient or not?
So maybe staff can clarify that, but in my experience in the hospitals I've worked at, it's always been a separate prescription number and labeling.
I'm just wondering, in this case, then would these count in a hospital setting for outpatient prescriptions that would be tallied for our previous discussion for CAMR, like the 1%, the less than 1% outpatient prescriptions to count whether they're excluded or included? I don't know if I'm wording that correctly. Does that make sense? Just wondering if this bump people up over the, whether they have to report, because if they just, these drugs that go home with the patient, are they outpatient prescriptions considered?
So staff, do you have any comments or on that? I can tell you what my experience is, but that's just my experience. So in my experience, it's the hospitals that I've worked at has always had a relabel program. So I don't see that in those facilities that there would be an increased number of prescriptions because they currently do that. There may be facilities that don't, and so that may change for them.
This is Corinne. I mean, I will just chime in to your question about the hospital pharmacy regulation, just to say, the way that it's worded and the way that I read it is that the 1% applies to walk-in customers.
Oh, okay. Thank you.
Well, okay.
I guess if they walked into the emergency room. Anyway, okay, this probably does not. I just kind of wanted to ask that question.
Mm-hmm.
Go ahead, Keith.
This may have been discussed, but what will be the pharmacist's requirement for counseling or consulting when patient is discharged to home from the emergency room?
So this was what we talked about when the bill was being discussed. So this is from the emergency room and bypasses the pharmacy and the pharmacist.
Right. Yep.
Yes.
Yeah.
Yeah.
So I think this is
At that time, we did ask for amendments and they were not accepted.
I think this is pertaining to a prescriber dispensing
Right.
of unused portion. So that's probably something to keep in mind.
So it is really, again, it is an unused portion of a single dose or of a multi-dose single patient thing. So it's like eye drops, inhalers, topical ointments. So there are limitations on the types of drugs, and there are specific requirements for labeling. Any other comments from members? I know this is going to be confusing to the public, but Claudia.
I just wanted to ask the staff in terms of the implementation. This is going to be, our communication to the licensees is going to be done, I see here in the notes, through the script. We're going to be updating other sorts of information. Any additional things that we might be able to do to provide more clarity?
So I think that sometimes we have to kind of see how it's being operationalized in the field to maybe gain some additional understanding of where there might be additional items. If we determine that like FAQs might be appropriate or those kinds of things, we'll definitely bring it back to the chair of the committee with a recommendation to maybe consider some things. But I think at this point, because it hasn't necessarily been implemented yet, I think we're, kind of going with some of the basic things. And then as we understand where there may be gaps in information, looking to see if the law provides additional clarity that we can leverage for FAQs. Hopefully that kind of makes sense.
Yeah, that sounds great. Thank you.
Any further
Yeah, I
comments?
just wanted to.
Oh, go ahead.
Oh, sorry. I just wanted to chime in from what I understood from explanation the council gave and reading of it is that seems like the intent is to not delay a treatment so the patient is receiving these doses that you would be wasted otherwise if the pharmacy is now open at the time to relabel it for them to take it home. This way they can go home and the prescription could be provided to them to be taken home. I think its scenario is more for like, I don't know how often that happens in pharmacy. I mean, in emergency rooms, I'm not, I don't work in that setting. So I think I agree with and that, we would see how, if there's an issue with this and then provide, as it's necessary, more clarification.
Claudia?
Yeah, and also seems that this could be a good way for people to have access to their medication right after they get discharged. Because I know from my experience with my family, it could be hard for certain individuals to get to the pharmacy and pick up their prescriptions. So we'd love to keep an eye on this and work with the staff to make sure we implement it correctly.
Any other comments? Okay, we're ready for public comment in Garden Grove.
Not at this point.
Okay, moderator, we're ready for public comment for people participating via WebEx. All right, if you'd like to make a comment, please find that hand raise icon on your screen or device. Either the button at the bottom of your WebEx screen, the ellipses on your mobile device, or *3 for calling users. And our first comment comes from Tim Lopez.
Tim, I've sent a request to unmute.
Yep, thank you. My name is Tim Lopez, a registered pharmacist that works with community medical centers here in Fresno, California. Yeah, so the concern with this is our inpatient pharmacy, like many other inpatient pharmacies, do not have the facilities to meet the labeling requirements that are described in section 4076. So that would be a rate limiting step for us. In addition, I agree with one of the members' earlier comments that I think it'd have to be clarified whether or not this counts towards an outpatient prescription and that 1% rule that's described in section 1710, because the way I read it is that it would be. So I would like clarification for that as well too. Thank you very much.
Thank you. Not seeing any further requests, I'll return the floor to you.
Thank you. And I guess just to provide clarity, there are hospitals that are already doing this, but via a pharmacy program where the pharmacy pre-labels and has logbooks and all sorts of documentation that the medications go pre-labeled correctly to the patient. Those facilities that don't have the pharmacy involved, this law now allows it to bypass the pharmacy. So the prescriber, the physician, or prescriber would be still required to label those medications just like they do currently when they dispense from their offices. And we know that that's not often done correctly either. So members, any other comments before we move on? We knew this was a problem prone one. Yeah, it's something that I've talked about since the very beginning.
This is Renee. I think there, just throwing, because I think there are a lot of nuances here, and it may be that my experience is in pediatrics. And so the usage of some of these unit dose in the emergency room is different than for when they go home. So, that again, that would be just part of this discussion.
So unit dose is not applicable. They don't go home with you. It has to be a multi-dose, single patient use product. Any other comments from members? I'm sure we're going to talk about this again as questions come up once it's implemented.
Yeah, I have a comment about record keeping, especially what has been given to patient and where would be the repository of that? And would that be under purview of, let's say, board inspector when they go and inspect?
That was one of the concerns the board brought up when this was being discussed, because it bypasses the pharmacy as in their inventory, and it also bypasses the pharmacy for documentation. So there are no pharmacy records, but I'm sure that the emergency room record would have something. They do document what care happens in the emergency room. It just would not be part of the pharmacy record. We tried to bring up those issues with the amendments, and those amendments were not accepted.
Thank you.
Okay, moving on to Senate Bill 40 related to health care coverage and cost restrictions for insulin. Members agreed with staff recommended implementation activities. Additionally, members highlighted the committee meeting that federally qualified health centers that purchase insulin at 340B prices, there are separate requirements based on a White House executive order. Members, do you have any comments on SB 40? Nicole, I know you're the one that mentioned the executive order. Did you want to comment on that?
No, you covered it. My whole point with that is just for people who are at FQHCs to know you have to follow both. This does not replace the other one. It is two separate things.
Thank you. Members, any other comments? Seeing none, we're ready for public comment in Garden Grove.
None at this time, Chair Serpa.
Thank you, moderator. We're ready for public comment via WebEx.
If you'd like to comment on this bill, please raise your hand. Clicking the hand raise icon at the bottom of your screen, accessing that hand raise option through the ellipses for mobile users, and for call-in users dialing *3. I'm not seeing any requests come in, so I will return the floor to you.
Thank you. Moving on to SB 41 relating to pharmacy.
Sorry, Maria, this is Jesse. I just raised my hand late, but just thought of something of note. My understanding of this, and correct me if I'm wrong, is that this applies to insurance companies. And so it may be a good idea for us to have some outreach to pharmacies about this. I'm not sure how it applies to, say, a discount card, but if you do have patients who don't have insurance and are used to using something, some sort of discount card, it may be good to make sure that pharmacists understand this sort of program. I mean, it sounds like it only applies to insurance, so I don't know if that comment is necessarily relevant, but just wanted to throw that out there.
Thank you. I think the materials say that we were looking at providing information to licensees and the public.
Perfect. Thank you, Maria.
Thank you. Any other comments before we move on? SB 41 relates to pharmacy benefits managers and prohibits them from requiring patients to use only affiliated pharmacies or from discriminating against non-affiliated pharmacies in dispensing drugs. Beginning in January 1st, 2027, PBMs must be licensed by the Department of Managed Care. Members noted agreement with the staff recommendation implementation activities. In response to a recommendation by the committee, staff has contacted counterparts at DMHC for coordination purposes. Members, do you have any comments on SB 41? I don't think there's any comments in Garden Grove.
Not at this time, Chair Serpa.
Moderator, we're ready for public comment via WebEx.
We're opening up public comment on this bill. If you'd like to make a comment, please access that hand raise icon. Our first comment comes from Sean Kim. Sean, I'm sending you the request to unmute your microphone.
Good morning, board. Sean Kim from CPHA. CPHA strongly supports the implementation of SB 41 as the bill's sponsor. SB 41 is a monumental step towards transparency, fairness, and accountability with pharmacy benefit managers. We applaud the collective multi-year advocacy across all practice settings and interprofessional partners and the board supports that advanced transparency across the healthcare system. SB 41 complements with the budget bill AB 116, which was signed June 30th, which requires PBM licensing through DMHC, Department of Managed Healthcare. Together, these measures directly address long-standing barriers to patient access and health system viability across settings, not only community-based pharmacies. CPHA agrees with the board's plans to emphasize education through the annual changes in pharmacy law webinar, the script, and the consumer-facing outreach. We also encourage close collaboration with DMHC to ensure the coordinated framework for complaints intake, investigation, and enforcements, particularly during the PBM licensure transition prior to January 1st, 2027. Effective oversight will also require active communication with HCI, Healthcare Affordability and Information's Healthcare Payment Data, HPD program, which will collect and analyze PBM-related data such as drug codes and names, prescriptions and patient counts, discounts, rebates, information needed to access payments to PBM-owned pharmacies. So this is a lot of information that has to be sorted through with interdepartment of efforts. So according to the HPD's PBM data collection roadmap, PBM registration begins in 2027, and historical ongoing data collection starts in 2028. Important across agencies and professions, wide discussion will be needed to align timelines and data elements and use cases. CPHA encourages board members and the public to participate in HCI and DMHC public meetings and stakeholder meetings to support proper implementations. It is critical that pharmacy professionals in the field are essential to ensure the right data to collect and analyze and effectively address PBM misconduct, and which ultimately harms consumers and patients,
10 seconds.
contributes to the healthcare desert. Thank you so much for letting me comment today.
Thank you.
And seeing no additional requests for comment, I'll return the floor to you.
Thank you. Members, any further comment on this measure? Okay, moving on. The next measure is SB 306 pertaining to prior authorization for healthcare coverage. This bill requires healthcare service plans and insurers to temporarily exempt certain services from requiring prior authorization if 90% or more of the requests for those services were approved in the previous calendar year. Members noted agreement with staff recommended implementation activities. Members, any comments on SB 306? I can't see. I think there's no comments. Is there any comment in Garden Grove?
None at this time, Chair Serpa.
Thank you. Moderator, we're ready for public comment via WebEx.
All right. For comments via WebEx regarding this bill, you can raise your hand using that hand raise icon. And Chair Serpa, if you'd like, while we wait to see if anybody wants to comment, Claudia Mercado does have her hand raised.
Okay, we'll come back. Let's finish with public comment.
All right. I have no requests, so I'll return the floor to you.
Thank you. Claudia, sorry, did I miss you?
It's okay. I was going to ask staff, it did say that part of the implementation, they recommend consumer-facing education activities. Can you guys briefly speak on that?
So I think as the provisions, so let me first say that like the provisions don't take effect immediately, right? So as the work starts to go, we do think that there's an opportunity to at least include some information on our website that lets consumers know where prior authorizations are not going to be allowed any longer, just as a way to try to help, consumers understand maybe some places where, knowledge is power, and helping them understand where they can maybe, advocate a little bit better to get access to the medications. I think the underlying policy is to try to remove these barriers to care. And so as it gets implemented, we think that there's probably an opportunity to let consumers know.
Thank you.
Thank you. Any other member comment before we move on? Okay, the next measure is SB 470, which authorizes state bodies and advisory boards to conduct public meetings via teleconference through January 1st, 2030. Members agreed with staff recommended implementation activities. Subsequent to the committee meeting, staff suggested that the board might consider updating the board member procedure manual regarding the frequency of meetings policy from an interim to a permanent policy through January 1st, 2030. The proposed update to the procedure manual can be found in the meeting materials under attachment 5. As I open up for member comments on SB 470, I would entertain a motion that it be included, the motion that is included in the meeting materials and displayed on the screen, should be coming up on the screen, if you believe such an action is appropriate. Members?
I'm more than happy to make a motion, Chair Serpa, to approve the proposed update to the board member procedural manual frequency of meetings policy from an interim to permanent policy through January 1st, 2030. Or can I make it more flexible and say if the bill is extended again, that we could just go along with that? Corinne?
Excuse me, are you saying you want to?
Through January 1st or further?
Yeah, you can do that.
Okay. Or if the bill is also extended at that time, that we would automatically be allowed to continue the policy. Thank you, Ricardo. I won't be around 2030, but just for the future.
Okay, so we have a motion and a second. And just to be clear, the motion is through January 1st, 2030, or such future dates as authorized by legislation or something like that. Corinne, is that
Yes.
okay to say it that way?
That works.
Okay, thank you. Any other member comment? Okay, any public comment in Garden Grove? Okay, none. Any public comment? Moderator, we're ready for public comment via WebEx.
All right, if you'd like to comment on this motion via WebEx for our WebEx users, please raise your hand using that hand raise icon at the bottom of your screen. For our mobile users, you can locate the ellipses to find that prompt. And for our calling users, you can dial *3.
Just confirming there was no public comment in person.
Thank you.
Go ahead, Shelley.
That's fine. And not seeing any requests for comment on WebEx either, so I return the floor to you.
Thank you. President O, I turn the meeting over to you for the vote.
Thank you. Was there any other comment? No? Okay. All right. Jesse, how do you vote?
Yes.
Thank you. Trevor?
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Back to you, Chair Serba.
Thank you. The next measure for discussion is SB 497, which prohibits healthcare providers, insurers, contractors, and employers from disclosing medical information in response to civil or criminal actions based on laws from other states that penalize such care. It also bars cooperation with out of state or, where permitted, federal law enforcement agencies attempting to identify individuals involved in legally protected healthcare activities. Members noted agreement with staff recommended implementation activities and suggest that some education or guidance on this topic may be appropriate. Members, any comments on SB 497? Sure, someone's gonna say something. I can't see you.
We don't.
Okay. I know during the public comment, there was comment that there is some confusion amongst licensees, and that's why the committee is suggesting additional educational guidance. Any public comment in Garden Grove?
We do not.
Moderator, we're ready for public comment via WebEx.
All right, to comment on this bill, please raise your hand using that hand raise icon. As a reminder, our commenters have a 3-minute limit, and we do provide 10-second reminders. And seeing no requests for comment, I'll return the floor to you.
Thank you. Moving on to the next measure, SB 568 expands the authority of pharmacies to provide a broader range of epinephrine delivery devices, including those other than auto injections, to local educational agencies, including school districts, county offices of education, and charter schools, under existing safety and training requirements. Members agreed with staff recommended implementation activities. Members, any comments on SB 568?
None in the room here.
I
I
don't.
see Jesse has on the hand.
Jesse, yeah. I
Jesse.
just wanted to comment my appreciation for the expansion as someone who has food allergies and recently had an allergy. Honestly, it would be a lot easier, and I think we can save so many lives by making epinephrine as widely available for people as possible. So that's all, and I agree with the staff's recommendation as well.
Thank you.
Well, also just to chime in here, with our AB 1503, pharmacists can initiate and furnish EpiPens and all kinds of stuff. So just want to point that out.
That's true. Thank you. Any other comments from members? Okay, how about public comment in Garden Grove?
We do not.
Okay, moderator, we're ready for public comment for those participating via WebEx.
All right, for our attendees on WebEx, you can raise your hand or request a comment, clicking on that hand raise icon at the bottom of your screen, locating the hand raise prompt under the ellipses for mobile users, and dialing *3 for calling users. Seeing no requests, I will return the floor to you.
Thank you. Members, any comments on this topic before we move on to the next topic, enforcement statistics? We'll take this opportunity to also circle back with Paige Talley. She had public comment on item A, duty to consult, I believe. And we were not able to hear her, but is she there now?
I do have an email from her with her comment. She's been having some issues with her microphone unmuting. She says that she uses a popular drugstore that is on every corner. And when she picked up a drug for her son, she was consulted. And when she told the pharmacist what the drug was going to be used for, he adamantly said no. It will not treat a facial fungal infection, especially if there are open wounds and they are bleeding. She was so very appreciative of the consultation, although had she not told the pharmacist what the medication was to be used for, the result could have been disastrous.
Thank you. Members, I think maybe Corinne, is it appropriate to ask members to comment on item A again, since we added additional public comment? What's the correct structure?
I mean, if you would like to, but then I think you'd have to open it up again for
Okay.
public comment.
Members,
think
are
we're
you
good to
okay with
move
us
on.
moving on to the next agenda item?
Yes, Chair Serpa.
Okay. Thank you. Item, I don't have a letter on here. The last one, summary of discussion of enforcement statistics. The meeting materials include a summary of enforcement statistics for the first 3 months of fiscal year 25-26. The board has initiated 914 complaints and closed 747 investigations. As of September 30th, 2025, the board has 1,736 field investigations pending. The materials provide a breakdown of the average time frame for the various stages of the investigation process. And attachment 6 includes the statistics for the first quarter of the fiscal year. Members, do you have any comments or questions on the enforcement statistics provided? Seeing none, do we have any discussion from public in Garden Grove?
We do not, Chair Serpa.
Thank you. Moderator, we're ready for public comment for individuals participating via WebEx.
Thank you for our WebEx members that are joining our meeting today. If you'd like to comment on this item, you can raise your hand by clicking that hand raise icon at the bottom of your screen. Our mobile users can locate the ellipses to access the hand raise feature, or our call-in users can dial *3. And at this time, I'm not seeing any requests for comment, so I will return the floor to you.
Thank you, Shelley. Thank you, everyone. President O, I turn the meeting back over to you.
Thank you, Chair Serpa, always, and all the committee members. We are ready to start on agenda item 13, but we will take a quick bow break. So we will come back at 11:35. 11:35, it's 11:28. We'll return in short 7 minutes. We'll see you all back. Sorry to WebEx members not promptly coming back at 11:35 as promised. We're gonna get back on it. Jesse, are you back?
Yes, I'm here.
Yes. Trevor?
Present.
Thank you. Renee?
Present.
Thank you. Jeanette?
Present.
Thank you. KK?
Present.
Thank you. Claudia?
Present.
Thank you. Jay?
Present.
Thank you. Ricardo?
Here.
Thank you. Satinder?
Present.
Thank you. Maria?
Present.
Thank you. Nicole?
Present.
Thank you. And I'm here. Next agenda item is 13, Licensing Committee Report. As the chair of the Licensing Committee, I'm pleased to provide a report from the committee's meeting last month. As demonstrated in the meeting materials, the committee had a very long and productive meeting. As announced, we're extremely excited and grateful for the passage of AB 1503, our sunset bill. Lots to discuss. Thank you to my fellow committee members, Trevor Chandler, Renee Barker, Jesse Crowley, Claudia Mercado, and Satinder Sandhu. First, summary of presentations and discussion of pharmacy practice experience requirements pursuant to Business and Professions Code Section 4209. As the meeting materials reflect, pharmacy law establishes a requirement for an intern pharmacist to complete 1,500 hours of pharmacy practice experience before applying to take the pharmacist licensure examination. The statute further provides that an applicant that has graduated after January 1st, 2016, from an accredited college of pharmacy is deemed to have satisfied the pharmacy practice experience requirement. The meeting materials also include information on the updated ACPE standards that all accredited pharmacy school programs must satisfy. This includes completion of introductory and advanced pharmacy practice experiences in pharmacy world known as IPP, APP, or IPI, or EPI, whatever they prefer. As noted during the committee meeting, the standards establish rotation requirements and require completion of a total of 1,740 hours of experience. Members of the board have received comments suggesting that the board should re-establish a requirement for an intern to complete internship hours outside of the practice experience gained as part of their pharmacy education. During the meeting, members received 3 presentations on this issue from Dr. Sarah McBain, Associate Dean from University of California, Irvine, Dr. James Scott, former Dean at Touro University, and Dr. Scott Takahashi, a pharmacist at Kaiser Permanente. I am hopeful members had an opportunity to review the live stream of the meeting. As both the live stream is available and the meeting materials provide summary information, I'm not going to review the presentations, but I do note that I found the presentations and varying perspectives very interesting. Following presentations, the committee discussed this issue. Committee members shared their experience working as an intern, including myself, while progressing through pharmacy education. The committee considered if there is a potential means to incentivize rather than mandate pharmacy students to complete intern experience outside of their pharmacy education. As indicated in the meeting materials, the committee is not offering any recommendation, but is looking to the board for any recommendations or further direction from our members. Depending on our discussion today, the committee may schedule subsequent discussion. I do believe that the board could consider developing a policy statement and acknowledge that importance of gaining intern experience outside of APPs or APPs as one of potential means to convey the board's support to this additional experience without a mandate. I do not support mandate for myself, on my personal opinion at all, because I think that is going to be a very difficult way for us to navigate. The locations of pharmacy schools are very diverse. Some are in rural, some are in urban areas. So I think as much as possible to all students and interns that working outside of IPI and APPI experience, I just want to highlight that how important and valuable it is for our pharmacy students to work. So if there's any creative ways for our members, any suggestions would be welcome. But if at a minimum, we could develop a policy statement how the board strongly supports that endeavor. Members, any thoughts? Go ahead.
Yeah, I'll just say one of the things that was discussed at the meeting as rather than a mandate would be a potential certification that could be proactively pursued. So it's an if and rather than a mandate. So it could be an additional certification is like ready to work in a clinical session. So I think there's ways to incentivize without mandating so that those who wish to pursue it can get the credit and recognition as part of their professional development. So I think there's some good ways we can pursue on this.
Thank you, Trevor. Jesse, your hand is raised. Go ahead.
Hi, thank you. I actually think that there should be a mandate, to be honest. I've been a preceptor basically since 2015, and the students that I see who work consistently are the ones who tend to be the most knowledgeable and the most prepared to go back into the workforce. Unfortunately, IPI and API alone, in my opinion, are not sufficient. It does not give you the hands-on experience of actually working in a pharmacy. And there are just some things you need hands-on experience for that you cannot learn from a test or from a book or just from a couple weeks on rotation. And so I actually would be supportive of a mandate. I'm curious how much of the non-work experience has anything to do with, the decreasing passing rates for some of these exams. And I will say, when I was an intern, granted, it was not in California, but it was a very competitive process to even get hired as an intern. And almost all of the workplaces did have a minimum working requirement. So for me personally, in my district, it was a minimum of 8 hours a week if I wanted to retain work. I know at other workplaces that were more competitive, say you worked in a hospital, it may be even 16 hours a week. But those students were definitely more prepared to become pharmacists, to transition to that role, and also more prepared for their exams after graduation.
Thank you for the comment, Jesse. I do agree with you for sure, but I think it just gets very difficult in terms of, I think that overall during the meeting, what we highlighted is there's so many additional layers of factors involved in terms of the quality or maybe, of what's going on out there for exams and everything else in between. There's generational changes, attitude changes, quality of student pools. So many factors, and I think, if anything, we can continue this discussion, but I'm not sure if a mandate would be appropriate at this time. Any member thoughts? Renee, go ahead.
Yeah, I just wanted to make a comment. I would somewhat agree with Jesse in that. I mean, I absolutely agree, and our experience has been that the experience that they get from a rotation, or not rotation, sorry, not the IPI or API, but from working basically as as an intern, is really valuable, again, to round out and to really solidify, and they see connections. So, I mean, with that said, I do think that with a mandate, it would be challenging for the number of students that are in California to find an intern position. I think there's not that many hospitals that hire any or very many. That could change right now. Like once they have that pool kind of dried up, once they were going to the year round, and the amount of time that they are available is much more limited. So their training is limited to what they can do at the hospital, in the hospital setting, my experience. But it is, again, very valuable. But I think I think there would be definitely, we get a lot of applicants, let's put it that way. So for our number of intern positions, which is not many, but we have a lot of applicants for those positions. And even so, it's not even close to all students looking for some. So, and I think it's just would be challenging because they have to be able to basically have that availability somewhere in a closer proximity to where they're living and going to school. But again, I would, I did my schooling here in California, and it was required at that time. And I feel like it was a challenge, but it was really worth the time. So I just wanted to add that.
Thank you, Renee, and I agree. I mean, every opportunity I get to talk to students, I tell them you need to work outside of, their schools. So, I mean, I'm highly, highly encouraging. Maria, I'll go to you.
Wanted to just add to the discussion because I can see how complex and how this will require a lot of consideration because there is no easy answer. You know, I agree with what we've heard that the quality of students is not the same as it was in the past. And what is that? Is that generational? Is it because we're not requiring work? Is it, what is it? It's just different. But it requiring work may not be the answer because it's not that easy. It's not just one, it's a multifactorial issue, what's going on. But also the ability to have workplaces for all pharmacy students would be tremendously difficult. It was difficult in the past when we had fewer pharmacy schools. And I, knew people who would drive over an hour just to get to their workplace. And then also workplaces are not willing to hire people unless they're there to work. I mean, 8 hours is, you could spend several months training someone before they can actually even work. And by then they're not there for you unless you're looking for a person working for you that will be full-time after they get their degree or their licensure. That is probably not happening either. So I don't have the right answer. I think we need to have some further discussion. I don't think it should be something that's like bonus points if you work, but I also am not quite sure how you would mandate it. But there really is huge benefits to having more work type of experience. I don't think that that's possible. That's something that the schools could do because in the rotations, the actual hands-on part of the work, in my experience, and of course I don't deal with that many students anymore. It's been the last about 5 years ago, probably the last time I dealt with some students, is very little hands-on, mostly clinical. And because of that, I think they've really lost some experience that I'm not sure how they can get back.
Thank you, Maria. So I'm guessing maybe let's hear from the public. I'm sure we have a couple people here. Oh, there. Yes, I was hoping maybe somebody from school would speak. So I know I'm sure Richard is not speaking on behalf of school. We're going to go to public comment and we'll continue our discussion and see where we're going to move forward on maybe potential solutions, if any. But we'll continue the discussion. So we're going to go to public comment in Sacramento. I'm sorry, we're not in Sacramento. I'm not moving around here. We're ready for public comment in Orange County.
Hi, Richard Dang, pharmacist and faculty at the University of Southern California, speaking on behalf of myself. I appreciate the discussion on this topic. There are very real issues around some workplace considerations and preparedness. However, I do agree with President O and many other board members that the return to the mandated 1,500 hours is not the answer to the problem that we are seeing today. I graduated from a California School of Pharmacy at the time when this was a requirement, so I went through that myself. I'm current faculty member now. I'm a preceptor for IPPI and APPIs. I'm a residency program director, and I train postgraduate residency pharmacists. So I definitely understand and agree with many of the comments that have been made. I think the comments from Maria and Renee about not enough positions is absolutely true. When I was a student, there were many students who couldn't get an internship job, and in order to be eligible for licensure, they had to sit out a year or two and then work afterwards, and that delayed their licensure, or they had to drive 1 or 2 hours to some other remote location that took away from their ability to study and prepare. Additionally, at the time when the 1,500 hours was required, the landscape for ACP requirements for schools of pharmacy were very different. The IPPI hours were not required. They were not standardized. Now they are at least 300 IPPI hours in addition to the APPE hours. There's a minimum required for all schools. So the number of experiential hours that's expected from schools of pharmacy has increased since pre-2016. Additionally, the didactic content that's required by ACP has also increased, which then means we have more didactic in classroom time. So while maybe pre-2016, the students had time to work 8, 16, 24 hours, they may not have that time to do that now, especially if they're in a curriculum where they have both class and it be happening at the same time in the same semester. So you have students who are going to class Monday to Friday during their experiential rotations, and some of them are working, and that's great. I tell all my students to work as well. But I think there's a lot of potential issues to the reinstatement of a mandated 1,500 hours that would just increase the burden on our students, our interns, our schools of pharmacy, our employers, and also on the board of pharmacy. If you'll recall, you had to have a lot of staff hours dedicated to verifying all of the intern forms that were submitted, calling employers, verifying hours, and I'm sure that reallocate a lot of resources that could have been spent on something else. Also, at the time, the intern hours were only applicable for students who are working in community and hospital settings. It did not recognize hours for those working in ambulatory care, pharmaceutical industry, or managed care. And many students are now working in those areas. And as we move to the standard of care model, you're going to want students who have those experience outside of hospitals and communities. So I appreciate the discussion, and I appreciate the committee's recommendation to explore other avenues and other ways to address the problem that we are seeing with some students and the generational differences, but the reinstatement of those hours and the mandated hours is not the answer. Thank you.
Thanks for the comments, Dr. Dang. Anyone else? Okay, we're ready for public comment in WebEx.
Commenters lining up. As a reminder, if you'd like to comment, please locate that hand icon, raise hand icon at the bottom of your screen. For our mobile users, you can access the prompt from your ellipses. And for our call-in users, you can dial *3. Our first comment comes from Brian Kawahara. Brian, I've sent you the request to unmute your microphone.
Good morning. Thank you very much for this opportunity. I tend to agree with what people are saying in terms of this is a pretty complex thing, because I'm kind of split as to whether it's a good thing or not. I don't think, having recently worked in an experiential area, the one thing that I do know that's a problem is that they don't get, in a lot of times, sterile compounding as something that they can do because of the mandates of 797 and the like. I think that's something that really hurts when they do go out to look for a job in the hospital. And I think it's important that we figure out some way to be able to get that type of experience to the students so that they have an opportunity to go into hospitals with some kind of understanding of what sterile compounding is and what they have to do during it. In terms of finding jobs, it's even hard to find places to place students for hospital rotations that are mandated by ACPE. So it'd be difficult to say, well, every pharmacy student has to go out and get a job. I think it's a good idea, but in terms of putting it into application, I don't know how easy it's going to be at this point in time. Thank you very much for your time, and I look forward to seeing how you approach this particular problem.
Thank you for the comments.
Our next comment comes from Chasney Johnson. Chasney, I've sent the request to unmute your microphone.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. Being a pharmacy technician, most of my experience has been in an inpatient pharmacy setting. Seeing students come in and having residency has been a pleasure, but some of the things that I do see as they come in is they're revamping roles that are already set in place, usually for a pharmacy technician. Some things that I would recommend or I would like to see is maybe being a teacher assistant in some like organic chem with real students who are trying to earn credits to go to school to be just like them. Being a pharmacy technician and going to class right after work or before work, students are not always taking the class as serious as it should be. So this would be a good example of just having somebody that just went through this whole process to be like a living example of like help you through the course and learning what you can be just by taking this course. And it would help like having teaching skills instead of automatically being placed into a management job position right out of residency. It kind of gives you a chance to learn and see the skills that their teacher just taught them. Thank you.
Thank you for the comments.
Next comment comes from Scott Takahashi. I've sent you a request to unmute.
Good morning, and thank you again for the opportunity to speak with the board and now with the license committee and now the board. Yeah, I presented a section just based on my experience as an instructor and preceptor. In response to some of the comments we just heard a second ago, IB compounding administration, I think that's an opportunity for ACPE to be petitioned to update its requirements or enhance its requirements to improve that as part of the required curriculum for graduates of schools of pharmacy and the PharmD programs. To address some of the issues related to the impact on pharmacy schools, I'm not sure if that's something the Board of Pharmacy needs to focus on. And it's not because we're being mean, it's just because we're the last stop to make sure that quality pharmacists are coming into the workplace. And there's sort of primarily supportive discussion of your personal experiences as pharmacy interns and as it relates to your experience in development as a pharmacist. But ACPE really has backed off from the accountability for the number of schools of pharmacy. Maybe California can't support 14 or 15 schools of pharmacy just because of the number of pharmacies that are actually active that actually take interns. And the other thing that's more generational, I think, that was discussed is that students are doing things we didn't do as interns. We didn't take a gap year. We didn't take vacations. We actually soaked up hours on our vacations. So if the Board of Pharmacy feels that the experience of internship hours is worthwhile and worth considering reincorporating into the requirements for licensure, I think that should be the guiding principle to make a decision, and that the impact on this number of schools of pharmacy may be self-limited already just by looking at the pass rates. It looks like we can only graduate about 1,100 candidates per academic year to pass the board exams coming out of California. That probably is indicative of the maximum number of students that can be engaged in the pharmacy curriculum. So again, I thank you very much for the opportunity to speak to the board, and I am speaking as an individual, RPH 42737.
Thank you, Dr. Takahashi. And again, thank you for the presentation you given during the committee hearing.
Our next comment comes from Nathan. Nathan, I've sent a request to unmute your microphone.
Hi, my name is Nathan Wadwani, and I'm a current P1 pharmacy student. I've noticed in our class, majority of the class actually wants to do internships. And the issue that we're having is just availability and barriers to entry. One is that, for example, I'm interested in clinical psych as well as informatics, and there's just I haven't found any internship opportunities yet. I also live in Oakland, so I'm pretty sure there's a high demand for psych services, and simply just getting connected to someone who's open for me to work with them flexibly to kind of learn the skills, I would love to do it, as well as more people in my class. So I don't know if the issue is really the requirement or not. I think it's just access, availability, and barriers of entry to really make it easy to start. And to be honest, the competitiveness and the application process, it's easier for me to keep my previous job that actually pays a lot more outside of pharmacy than it is to try and apply and get a role in it and work for lower pay as well. So just wanted to keep that out, put that out there, that we'd really like to have internships and if someone came to our school, made it easy for our interests that we're interested in and connected us, I think a lot of us would join it.
Thanks you for the comments.
And our next comment comes from Sean Kim. Sean, I've sent the request to unmute your microphone.
Good afternoon, board. This is Sean Kim from California Pharmacists Association. CPHA appreciate the board's ongoing review of intern pharmacist practice experience requirement. CPHA also supports the ensuring graduates are practice ready upon entry to the profession. However, CPHA cautions against reinstating mandatory hours in lieu of incentives, as a mandate could create inequitable financial and logistical burdens, such as operational and administrative, particularly for students and schools and employers, and even for the Board of Pharmacy. Instead, CPHA encouraged the boards to explore incentive-based models that promote optional and practice-integrated experience, such as number one, recognition of the credit for the programs and the preceptors, paired with the high-quality educational standards and incentives for the preceptors to ensure consistent quality of experiential learning. This is broader systemic transformation that is required. Number two, partnership between the schools of pharmacy and the employers, acknowledging the operational lifts for the schools and the employers to create and sustain these opportunities. These points reflects not only CPHA's position, but also the collective inputs from the last week's California Pharmacy Council CPC meeting in San Diego. CPHA remains committed to working with the board and schools and preceptors and the practice sides to ensure the intern pharmacists to receive comprehensive, high-quality experiential education that builds the professionals' competence and readiness without imposing the operational barriers. Thank you so much for letting me comment.
Thank you for the comment, Sean.
And it looks like that is the last of our requests for comment. I will return the floor to you.
Thank you. Okay, members. Jesse, your hand is raised, so I'll go to you first, and then I'll check any other member comments, and we'll move on.
Thank you, President O. I really appreciate this discussion. I think this was great, and we've heard from a wide range of people with great perspectives. Kind of thinking out loud on this, because I know that there are huge barriers, especially if you have to go far. And echoing a little bit of what Dr. Sean Kim had mentioned, I think there needs to be some sort of incentive specifically for the pharmacist preceptor, or possibly even the pharmacy itself, to encourage pharmacies to actually hire more interns. I know this, and I will say I'm speaking from the retail perspective rather than the hospital, because I know that may be a little different. But creating, I don't even know what that would look like, but if there was a way that we could create more incentives for the licensees, maybe that can help kind of bridge the gap there. I really also appreciate the intern hopping on this call. I know that's not as common, but it's a very important subject, and it's really great to hear from a pharmacy student with their perspective.
Thank you, Jesse. Maria?
I look forward to having further discussion about that, and so maybe there are some unique and interesting incentives to work. And one of the things that just came up the top of my head, and I'm not quite sure how this would work, but some sort of incentive, like a decreased application fee if you have so many hours, or intern license fee. For some people that might make a difference. For others, it may be not worth the bother, but I still think some sort of discussions about incentives to work, and maybe not mandated. I look forward to further discussion.
Thank you, Maria. All right. Any other member comments before we move on? Oh, Satinder, go ahead.
This is a great discussion. I love it. I think we all agree that more experience provides a better entry into the profession. So we're just figuring out, it's just problem how we solve this. And Maria, you just took it. I was just thinking along the same line in terms of incentive of like maybe lowering the fee for getting the pharmacist license. The other thing that I was thinking was, instead of focusing so much on the intern hours, and yes, we can have a policy to encourage them to get a job or get experience, but also, like some in the other professions, I'm thinking of doctors, they don't have a specific requirement that they need to be working. They have after they finish their education, they get certification in some ways, like they're board certified in this, board certified in various practice settings. So it could be an incentive for them to be within their first year of practice, whatever practice they choose, because there's such a when we say ready, there's so much a wide range of practice settings that these days available to the pharmacists. It could be if for them to be get a certification, it could be certification offered by, I'm just thinking ACPE or CPHA or various different organizations. It could be employer based, maybe something along those lines. So because our goal is to their competent pharmacists and they're ready, go into the profession, and then once they're there, they continue to be competent.
Thank you, Satinder. Any other member comments?
This is Renee.
Go ahead.
I think one comment I would have about that is I do think that once the students graduate, they are, sitting for the boards to get their license or licensing exam and probably really needing to work since so many have student loans. So I don't think proposing anything post-graduation, I just don't see that people would kind of viably be able to do that. One discussion in the meeting was also that, I mean, there are students who probably could really it'd be helpful for them to earn money. It's not like they're earning a lot, the interns, but they're earning some. So we have had people who they just said they really need to work. So they, because the extra money helps. And I think just considering that, but not that the pharmacy school, I mean, I know they can't, that's not necessarily an incentive for them. The students have loans, but I mean, it's the reality for some students as a barrier. I just wanted to make a comment. I appreciate wanting to get sterile compounding experience near and dear my heart, but I do feel that sometimes the interns currently now, again, I agree, there's not the training and qualification to be able to do that. And I mean, just to qualify to be able to be trained to do sterile compounding, and it's so many hours, they don't work enough. But I do think there are things that are very little more entry level that they observe all the functions and alongside pharmacists, seeing what pharmacists are doing. And I think that's the real value in that. So again, I wouldn't necessarily agree with a mandate, but if there was something close to a mandate-ish, that it would be a lot less hours. I mean, not talking about the 1,500 at all. So just going to add that.
Thank you, Renee. I know KK wanted to say something, seems like. Oh, and then Jeanette. Okay, we'll go to KK, then Jeanette.
Just a quick comment. I think it is vested interest of the profession itself to prepare the deeply knowledgeable next generation of pharmacists. However, we have to look into the economics of the businesses that can support the internship or training, because with current model, the staffing and labor requirement to run a pharmacy in any setup, long-term care, hospital, you name it, it's quite prohibitive to add more labor to that model. So yes, this is definitely needs to happen, but we also need to look at the economics that can facilitate that, so they can be interns or residents for longer and get deeper knowledge.
Thank you, Jeanette.
Oh, great conversation. So thank you, everybody. I would just hope that as we talk about this further, that we think of short-term and long-term solutions. And I really appreciate the public comment. The comment was systemic transformation. I think we need to look at institutional change in the long term.
Thank you, Jeanette. Anyone else before we move on? I will probably be able to say that we'll definitely have a policy statement. I think that's definitely a step. We'll look further into the continuing discussion if there's any ways to incentivize, and also just something that Maria said is very brilliant. We'll see how much of we can do, as well as maybe looking into but intern ratio that's currently in our statute. So many things we'll explore, but Jeanette, thanks for providing the perspectives of the short term and maybe long term, and perspectives of how we can, continue to discuss this matter. With that, we're ready to move on to our next. Man, I thought this was going to be quicker. You guys are good. I like it. Okay, so next, the biggie is now Summary of discussion of changes in pharmacy law included in and proposed implementation activities regarding Assembly Bill 1503, Berman, Chapter 196, Statutes of 2025, including possible discussion and action to approve policy statements regarding transition of standard of care practice model, the role of the pharmacist in charge, and also to initiate rulemaking to add Section 1717.11 related to remote processing of prescriptions to California Code of Regulations Title 16. During the meeting, the committee dedicated significant time discussing recommended activities to implement the various and significant changes made in AB 1503, the board's sunset measure. Again, I'm just so excited and truly believe this will make so much improvement to patient care in the coming years. The meeting materials provide summary of the committee's discussion and public comment received, so I will keep my remarks for the various items brief as possible because it's a lot of stuff. So starting with new section 4001.5 related to Pharmacy Technician Advisory Committee. I will need a lot of input from you all. The section now will require the board to establish an advisory committee to advise and make recommendations to the board on matters related to pharmacy technicians. The committee shall consist of four licensed pharmacy technicians representing a range of practice settings, 2 licensed pharmacists, one of whom shall be a member of the board. So it has to be one of our members who is a pharmacist and shall be appointed by the board president, and 1 public member. So total of 4, 5, 6, 7 members. As included in the meeting materials, the licensing committee recommends the board establish an online application process. Appointment terms will generally be 4 years, with the first appointments for some positions shortened to allow for staggered terms over the long term. The committee also recommends that the licensee appointments have at least 3 years of experience as either a pharmacist or pharmacy technician with a single employer. The application process should include 1 letter of intent along with 2 letters of recommendation and a CV or resume, hopefully not written by AI, please, for the love of God. Please, for the, we're just putting it out there. Well, it probably will be, but whatever. The pharmacy technician appointee should represent different pharmacy practice settings. You'll note that the board is seeking guidance from members on the appointment process. Should appointments to the PTAC, PTAG, we're going to figure out where it lands. Probably PTAG. I like that, but it's okay if you all disagree. PTAG. Other than appointment to the pharmacist member who is a member of the board and shall be appointed by the board president, it will be delegated maybe to 2 members of the board. Or does the board prefer that the board or committee of the board appoint members? If the board prefers either appointment by a committee or the full board, reminder that the process must be done in a public meeting, allowing the public participation and public comment. I do think this can be a little bit challenging, so I'm hoping for more flexibility. Maybe we can always revisit this issue in a year or 2, depending on how it goes. So I really do need some input from our members on how you all feel about this appointment process. I am very indifferent. We can look at 2-member volunteers for 1 seat kind of a way as well. I think that's a possibility. So anybody who would like to be engaged in this process, please volunteer and let us know, and we'll see what we can do. I know, Maria, your hand is raised, so I will go to you. Go ahead, Maria, and then I'll go to you, Jesse.
I'm supportive of this. Of course, it's something that the board needs to do. I would just encourage that we have spent some time on how we package this for informational, and that includes the name of the committee. I think the legislation has a name, but we need to look at existing committees either in the state or nationally that use PTAC as an acronym, or they were to use that. That's it. Thank you.
Thank you, Maria. Jesse?
Thank you, President. Oh, the one comment I had is in regards to the employment. So I know it said that licensed appointees shall have at least 3 years experience first from a single employer. I just want to clarify if we specified when that continuous work is, especially now considering all of the Rite Aid closures. I just want to make sure that if someone had previously worked for an employer, even recently for that chunk of time, but maybe recently changed due to things like pharmacy closures, that doesn't prohibit them from being able to be appointed. So I'm not
Thank
sure if we
you.
actually clarified the work experience aspect, but I just want to be as flexible as possible for technicians who may be applying and do have significant experience.
Thank you, Jesse. Yes, I think that that's a flexible thing we could amend and change as necessary today. So members, please speak your minds today on this process. If you are indifferent, understandable, but nobody seems to have strong feelings on this. So Renee, go ahead.
Yeah, I mean, I would agree some flexibility, perhaps a rewording of the 3 years of experience from a single employer. I mean, if, do we, if they get renamed, I suppose that's single employer, but I don't know, there's always circumstances that are hard to like think of at
Maybe
this moment.
single employer instead of single employer, like a single setting? Would that be more tolerable? Like if it's a community pharmacy, at least 3 years in a community pharmacy setting?
Yeah, I think to probably
Would
have
that be more
I
tolerable?
mean, if they had promotions
Or
in there, it's regardless of
okay.
their maybe, there's still a technician in there, but what's their function? Like, do we, if they're being promoted in there, like that should be fine, of course, but like, I don't know if that fits into this wording, just making sure.
Okay, and Satinder?
I was saying that it could be in the same setting because, people tend to move and they may go to a different employer, but they also, the experience be more recent, not somebody who's a tech a while ago. So
Thank you. And then I'll go to you, Maria, then Nicole.
No.
Oh,
I'm
and I'll go to you after Jay.
Just
Go ahead,
wanted to
Maria.
add one thing. I think it's obvious, but I think it should be put in writing that the applicants be current California licensees in good standing.
Yes, that's absolutely. Thank you, Maria. And Nicole?
Just a clarification, sorry, I got confused when we were talking about the people, like board members being on the committee. The majority of the people on this are going to be technicians, right? It's just like
4 technicians, 2 pharmacists. 1 pharmacist will be someone that's not on the board, and the other pharmacist is someone on the board. So among 7 pharmacist members, one of you will have to volunteer, and please volunteer. And then 1 public member. My unclearness is that public member, I believe, can be a board member who's a public board member, can be that public member as well if you choose.
got
But
it. And so, and how many people are technician members? That's the piece I'm
4.
missing.
4.
Got it. Okay.
All right. Jay?
What's the intent of the original wording for having the 3 years under a single employer?
At the committee level, it is that we're hoping for people with relevant experiences, really who's practicing as pharmacy technicians, to be providing their insights of their daily jobs and responsibility and how we could make that into workable kind of a solutions, providing recommendation to the board. Someone who's not like in more of an administrative position, but more of someone who's on front lines, right? Kind of that thinking.
Okay, so much like what Satinder said, if there's not a disruption in terms of the learning process or the specific field that they're going into within pharmacy, there's nothing that disrupts that intent for them to go from one place to another. Is that correct?
Seems to be, if we're going with a setting, right? Similar setting. Yeah.
Yes, I would definitely just push for them to be in the same setting.
Thank you. And Jesse?
So I'm a little on the fence, honestly, about the setting. I think that it makes the most sense for the positions that are specific to that setting. For example, in community, of course, it makes sense that the 3 years experience has to be in community. Same with hospital, but for the unspecified seats, I don't know that the setting holds as much weight of importance. But with all that being said, I trust that whoever's going through these applications will use their best judgment. And so I pass that evaluation really onto them. For me, it doesn't make it as much of a difference, but
Oh, well, I mean, we can also look at it for the 2 assigned category seats, we do not require that single setting either. So again, remember board, this is a very flexible, the statute was not as clear in what we do, so we kind of have some discretion on how we want to move forward.
This is Renee. I just feel like there should be at least some consistency about the requirements.
Okay.
So, to have require a minimum of 3 years for 2 positions, but the other ones not so much. I mean, I do think that there's a certain amount of mastery that comes with time. So, I mean, 3 years would be the minimum. I mean, where you don't, because it takes a while in any position, pharmacist or technician, but where you're learning like what you need to do, but you learn the interconnectedness, and then you learn how to do like improvement, process improvement, or so I think somebody would need to be in that somewhat frame of mind to know
Yep.
how like a little their position more globally, and how it fits into like as a larger profession, so that because they're going to be having impact, right? So I do think that minimum of 3 years should
Yes.
apply to everybody.
Okay.
What those other 2 positions are, since it's not specified, but I still think they should have some mastery in it.
Sounds
So I
good,
think the
Jay.
3 years.
Yeah, unfortunately, I'm a public member, so I don't know how the internships work so much. Are there learning agreements that are created when they do the internships, regardless of how long?
Technicians?
Yeah.
I think in technicians, usually the way it works would be that they know what job they're signing up for when they're applying for jobs, so that sometimes it's based on what kind of jobs they're in.
Hence the setting, right?
Setting, yes.
Okay,
So
so-
like someone who was working at Rite Aid, and so unfortunately Rite Aid is no more in this world. So in that community setting, most likely you're in a community pharmacy setting. So then that person can go work for Vons, and that person's, maybe accumulative experiences in a community pharmacy is 3 years, but that the job duties in a community pharmacy is pretty consistent
And are those written out, or is that
in
just
their job description.
Okay,
Yeah.
that's kind of
So
the
should
thing.
we then require job description of their job? I mean,
I don't know if you can, but maybe,
Yeah.
I mean, if that's possible, it seems
think
like
we'll
at
have
some
to
level
rely on
some of
their-
this should be standardized, and the other parts are nuanced because you're, with different employers, but
Yeah.
it feels like there's certain tenets that that you're gonna have to learn regardless of what type of setting it is. For this setting, you need to know these 300 things intricately. For that setting, you need to know these 200 things intricately. So it just seems like I don't know how standardized or not standardized that is at present.
Ugh.
Yeah, that look tells me a lot.
Probably not as standardized. Yeah. Okay, members. I do need help though in appointment process, because that's the more difficult. So, okay, so I think we're kind of getting with the 3 years single setting for 4 technicians. I think that's where we're landing in terms of just the discussions. We do need to figure out the appointment process, because that's where we did not have, as a committee, we did not have any strong feelings. We really didn't have any strong ways, desires on how we want to go. So I think one seat, pharmacist board member seat, is very clear that it's appointed by the president, but the other 6 seats are a little unclear. So other than the application process, so need some help here. So Maria, I'm hoping you have some magic bullet.
Well, I don't have
Magic
any
answers?
magic bullets, but I know the state is very, very specific about all sorts of things. And so my questions would be, what needs to go through HR, the appointment process, the who appoints and how are they, how are they termed? Is this I don't know what the state's requirements are for ad hoc committees versus ongoing committees. And, like all of us as board members, we get lots of stuff about not CE, but whatever it's called,
Requirement,
all those
training
things that we need
requirements.
to do and sign and fill, and because
Yep.
we're pseudo employees. So I think there's a lot of questions there that whatever's legally required, and then you could develop probably a subcommittee, or we could vote on it as a committee in closed session or something.
Okay. Go ahead.
So I'm not quite sure closed session is an option because the government code details out what the board can meet in closed session on.
That is correct.
So what kind of private thing could we do to review the applications? I mean, we certainly don't want to put the applications in a public meeting.
That's the decision making. We may have to if we go with one. So I'm thinking, I don't know where our members are on this, but I'm thinking at least at the beginning, like, so reminder that if we have two members deciding on one person, that could be done in a more of a not open meeting setting. So maybe there's 4 seats of public pharmacy technicians, and maybe each members, 2 of them can be assigned for each seat for appointment process at the first run about it and see how that goes. For example, I could team up with Jesse and I would be assigning that. I could team up with Jesse, Maria can team up with Claudia, or we could do pharmacist public member thing and just kind of go through the applications of that one member position for the technician member and then kind of go from there so that we have flexibility in terms of appointment, also transparency. So it's not just one person deciding, it's the board decision in a way, and kind of looking at that way. So I'm just throwing that out there. Jesse?
I was actually going to suggest something similar, just dividing it up with 2 members selecting it. I don't know if do we have enough members to do that 6 times? I guess that's
Well,
my
it would
first
be,
question.
yeah, it would be really
Okay.
5, 6, I guess. Yeah. In theory,
Yeah,
yes.
I guess it would be 5 members. I think that's a good idea rather than having it be public, truthfully, because of some sensitive information that may be in some of the applications. I wouldn't necessarily want that in a public setting, but I would
Yeah.
be on board with that. And then I would also be okay with the president kind of dividing the board up to go through applicants.
And the members who's deciding, right? Okay.
Yes.
Maria, go ahead. You're muted, Maria. Muted, Maria.
Talking to myself. One of the challenges with that is if someone were to apply to be a community technician and it were filled by another, they would still be able to be the unspecified position. So I'm not quite sure how that would work. The unspecified position could be a community tech or could be a hospital tech. So they should be able to apply for both. I know.
Oh, I see. Well, maybe there's a clearinghouse so that if there is you're a community. I mean, the intent of it is so that to get the diverse experience. So I would hope that there are different settings that technicians would apply so that if you're a community pharmacy technician, you would, at first, would apply to a community pharmacy technician seats.
So then you
So
have
that,
to be clear, I think, to say unspecified, not including community or hospital. Otherwise, the way the board works, for our board members, we have some seats that are kind of unspecified and they could be a long-term care, they could be a hospital, they could be
yeah,
one of the others.
yep. Members, what do you think of the idea?
Um, I guess does it not seem that those two unspecified practice positions are not community and hospital since they're not specified? So in other words, we don't have one or more positions representing community, one or more. Do you see what I'm saying? Like I feel like the variety is going to be really important. There's a lot of technicians doing a lot of different things. So, I think it would be important. It's not specified,
Yeah.
but I think it's important that we have like closed door pharmacy, long-term care facilities,
So we need to specify that non-specific setting is not for community pharmacy technicians, right?
Yeah.
Yeah.
Nor hospital.
Korean? Corinne?
Yeah, sorry, I was
Did I just call Corinne Korean? I'm sorry, Corinne.
It's okay, you got it. Just to clarify, in case there was any confusion for the members, I mean, what the statute says is representing for the tech positions, the 4 tech positions, representing a range of practice settings to provide a diversity of perspectives. So the statute itself does not say you have to have a community pharmacy person. So that's, the board's discretion to decide how you want to, reflect the range practice settings.
Thank you, Corinne. Jesse?
Thank you. I think that that actually helped to clarify some things, but I think part of the issue is at this point we don't know the practice settings that technicians applying are going to be from. And so we do run the risk of maybe there isn't a long-term care technician who does apply. I mean, I really hope that we do get a wide range of technicians. But if we do get to a point where we don't have as wide of a range of settings to choose from, it may be better to leave those two open-ended and give us more flexibility.
Go ahead, Trevor.
But then
Okay, thanks.
that becomes a bigger issue, because then I think we would have to continue this discussion more in like a public forum.
Yeah. Thank you, Jesse. Go ahead.
Yeah, going off of what Jesse said as I listen, the conversation is based on the assumption we're going to have a robust applicant pool, which I hope we do. But in my experience with setting up committees like this, especially as we raise awareness of it, I don't think we should overcomplicate it right away. I think we should just focus on getting it set up, getting people on it, in an expedited fashion, and then figuring out being a little bit more prescriptive and deliberate in the appointments after that. I mean, so that's just my personal experience on setting up kind of committees like this that might not have the same visibility. Is don't overcomplicate, get competent people that apply on, and then as it matures as a committee, being much more specifically intentional about process and specific slots. So that's just my contribution.
Thank you, Trevor. Maria?
I agree with everyone, but I'm just looking at the logistics, because if I'm applying and I click the community tech and you pick somebody else, that means I haven't applied for the unspecified. So there just needs to be some logistics so that those applicants for community and hospital are also considered for the unspecified, or some manner that you don't apply for one and then are no longer qualified for the other.
Got it. Thank you. Jesse?
Is there a possibility that, we put this application online, we just have one application to fill out, and then maybe we encourage people in the letter of intent to specify what position they're trying to fill, and that way we make it a little more open for the applicant themselves. And maybe once we receive the applicant, all of the applications that deadline closes, we may be able to meet or present at the board meeting the kind of settings that are there, and then revisit this conversation once we actually have the applications in before we divide it up.
Okay. Thank you, Jesse.
This is Renee. I just wanted, so I would agree with something like that, a very general, not people necessarily putting themselves into that. I think some of how to get the variety might be in how the messaging goes out. Unfrequently, maybe for technicians, and trying to make sure that all the settings are informed, something like that, that we're really looking for a wide range, so that somebody feels that even though they may not be the large pool of community techs, community pharmacy techs, that they could still apply and their input would be valuable, just so they understand that.
Thank you, Renee. All right, members.
I'm sorry. I
ahead,
would
Jenna.
also add, as someone who worked in the appointments process, that this will be an ongoing process. to
Yes.
Consistently recruit people, and I would agree with both members about keeping it general, and Trevor about working to manicure the process after we have our first shot out. The other thing I would ask is, are the farm techs going to be compensated even a tiny bit for their time? I mean, I'm just being the
Not
reality
sure.
of the.
We'll have to
economic-
examine that we don't know the answer.
Oh, okay. Thank you.
It's kind of an uncharted territory for us, just so we're all clear here. That's why we're like this is a fun discussion. Okay, so I propose maybe we have a committee of 2 members who will be assigned by the board president, maybe for maybe 2 technician members, another committee of 2 for another 2 technician members, committee of 2 for 1 pharmacist application, and another committee of 2 for public member. Does that make sense? I think that's where we're gonna start. And then we'll go from there. I'm gonna take the silence as an agreement. Okay. We'll start there. I hope that's gives a direction. Corinne, the only thing that I wasn't sure is, do we need a motion here? Because I feel unclear.
I think when in doubt, make a motion. There's no
Okay.
harm in making a motion.
All right. So with what I laid out, I'm just gonna make it easy. So I'll make a motion. That's a process, and then just encompassing all the others, which was a at this point probably best to do the community pharmacy technician member, hospital inpatient pharmacy technician member, 2 are unspecified members, 3 are single setting experience, stagger terms, which will be determined, committee of 2 board members assigned by the board president, or basically there will be 1, 2, 3, 4 committees. And to clear that if anything, the committee also forgot the part is the board has the ability to remove a member from the PTAC independent of a term expiration. So the board can vote to remove a member if necessary. So hopefully that's enough.
The only thing I would clarify is it sounded like you were specifying positions for the text. I mean, is that consistent with what the board, the consensus of the board? Because I also heard people saying leave it general.
Okay, so okay, I'm not sure where we landed on that. I heard 2 mixing things. So Jesse, go ahead.
My impression, or in my opinion, is that at least those 2 seats, like for sure, community and hospital should be represented, and then leaving the last 2 seats open. I'm in agreement with the committee's discussion on that.
Okay. All right. Are we clear on the motion, members? I'm sorry, this was a little bit of a discussion with a little no direction, so sorry for that. Okay. Do we have second?
I'll second.
Thank you, Satinder. Okay, public comment in person. Seeing none. Ready for public comment in WebEx?
For our WebEx attendees, if you'd like to make a comment on this item, please use that hand raise icon that you can find at the bottom of your screen. For our mobile users, you can find the prompt under the ellipses. And for our calling users, you can dial *3. Our first comment comes from Chasney Johnson. And Chasney, I've sent the request to unmute your microphone.
Hello, my name is Chasney Johnson, technician 106559, located in Oceanside, California. Being part of the Pharmacy Technician Advisory with the California State Board of Pharmacy, will there be a chance for a promotion to be a pharmacy technician and be able to attend regular board meetings? Because just listening and watching other states, for example, Nevada, pharmacy technicians are given a microphone to just say anything. And if we are given a chance to learn basic techniques, whether that's taking notes or being the moderator, you will be able to try out or apply to other community board meetings within your city. And that would be my feedback for today's agenda. Thank you.
Thank you for the comments.
And our next comment comes from Sean Kim. Sean, I've sent the request to unmute your microphone.
Good afternoon, board. Sean Kim from CPHA. First of all, CPHA applauds the board's successful efforts to advancing the Sunset Bill AB 1503, including the establishment of Pharmacy Technician Advisory Committee, PTAC, under Section 4001.5, which recognizes the essential and evolving role of pharmacy technicians in patient care. Pharmacy technicians are a vital engine of pharmacy, without doubt. CPHA supports the proposed committee structure and staggered 4-year terms, which will help maintain the continuity and ensure the representation across all practice settings. We also support the inclusion of the board pharmacist member to ensure the strong alignment between pharmacy technician perspective and regulatory priorities. Before appointing the committee members, CPHA encourages the board to clearly define and publicly communicate PTAC's roles and responsibilities so applicants fully understand their expectations. For instance, CPHA encourages them to assess workforce needs, such as Community Health Worker Certificate Program, which is called by the CMS Rural Health Transformation Program, continuing professional development, expand the scope and integration of the clinical workforce workflow to be aligned with the standard of care regulatory model under AB 1503. As the appointment process proceeds, CPHA also recommends including the competency-based selection approach. Beyond the years of experience, please consider leadership education, precepting, training experience so members brings the both practical and strategic perspectives. CPHA is committed to collaborating with the board to promote the growth and the professional advancement of California's pharmacy technician workforce. We look forward to contributing this process and helping ensure the PTAC strengths quality, competency, and collaboration across the profession. Thank you for letting me comment today.
Thanks for the comments, Dr. Kim.
Next comment comes from Rachel. Rachel, I've sent you the request to unmute your microphone. Rachel, you should see a button pop up on your end. Okay, I see you're unmuted now.
It just took me a few minutes. Rachel Miller, pharmacy technician, license number 17. Gosh, I just had it. Sorry.
It's okay. You don't have to
Okay.
say your license number.
I was just following along what everyone else is doing. Anyways, I'm asking for some maybe clarification. You're saying 3 years in a setting for the community and hospital. As a pharmacy technician that is not currently working in a maybe standard pharmacy technician position, would the other 2 seats also require 3 years in a pharmacy setting, or something else, if that makes sense?
Thanks for the comments.
Thank you. And our next comment comes from Cynthia Bennett. Cynthia, I've sent the request to unmute your microphone. And Cynthia, you should see an unmute me button pop up on your side that you will need to click to unmute your microphone. If you're connected by phone and computer with them linked together, you'll need to make sure both are unmuted. All right, I'm not seeing Cynthia's microphone unmuting, so she may be having some challenges with that feature.
We'll have to move on, Shelley. We're very pressed for time, so we'll return if we can get her audio back.
Okay, and with that, that's our last request for comment.
Thank you so much. Okay, just for clarification, I believe the expectation of where we landed is that community pharmacy and hospital pharmacy setting is appropriate, but the other 2, it's still the expectation that the single consistent setting experience of the 3 years. So for someone who's been in sterile compounding for 3 years, that would be kind of an experience that we would be expected, or some kind of an experience in a prior authorization, long-term care, 3 years in that setting would be appropriate. But again, we're not gonna get this perfect at right out of the gate. So we're just gonna, this will be a work in progress for us as we navigate this, this process and this committee. Members, before we call for vote, do we have any lasting comments? Ready for vote? Oh, okay. So, all right, Jesse, how do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Okay, members, so I'm being told that lunch is here, so we're gonna take a lunch break. We'll come back at 1:30 p.m., 1:30 p.m. and continue this discussion. We'll see you all back at 1:30. Enjoy your lunch. Hope everybody has delicious lunch. So we're gonna get back on it. Okay. Okay. Are we good, Cesar? Yeah, okay. Just gonna take a welcome back, members. I am worried we will lose quorum before we complete all of our work today, given that we are going to skip some discussion on the remaining items in agenda item 13B that does not require action. So with that, we're gonna move to, again, we're worried about losing a quorum before we complete all of our work today. So we're gonna skip discussion on the remaining items in agenda item 13B that do not require action. We're gonna move to amendment of section 4036 and attachment 1, pharmacist defined. Amendments to section 4036.
I'm so sorry, President. Oh, you want to take a
Oh,
roll call?
sorry. Thanks, Corinne. Look at me. I'm trying to get on with it. Jesse, are you back?
Yes, I'm here.
Thank you, Trevor.
Here.
Thank you, Renee.
Present.
Thank you, Jeanette.
Here.
Thank you, KK.
Yes, sir.
Thank you. I'm sorry, make you run. Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Present.
Thank you, and I am here. Again, thank you so much. And so we're moving to amendment section 4036, pharmacist defined. 4036 update the definition of a pharmacist to provide that the holder of an unexpired and active pharmacist license issued by the board is entitled to practice pharmacy as defined by the chapter within or outside of a pharmacy, within or outside of a licensed pharmacy. As the meeting materials highlight this change in definition, the committee is recommending the board promulgate regulations to more broadly establish provisions for remote processing. Members, included in the meeting materials is draft regulation language that the committee is recommending. As I open for member discussion, I note that the meeting materials and meeting slide include a possible motion that could be used to initiate a rulemaking to establish provisions for remote processing. I welcome comments from members and would also entertain a motion if you believe such action is appropriate. So again, we are on attachment 1 under the pharmacist defined. Members? I see Jesse's hand raised. Jesse.
Thank you, President O. One thing of note, and this comes up a lot of the times when I hear from pharmacists who are doing clinics, and how remote processing may assist them with that. But my question I guess, is if a pharmacist is to perform remote processing, say in a clinic, just using that as an example for immunizations, that comes up a lot, just to make it easier and get those claims processed in a timely fashion. How would the board really be able to inspect that? I know in theory and like in writing, it's saying here that the board would have the ability to inspect a location, but if it's a one-time thing, is that something that's realistic or possible?
I'm punting that to Anne on that question, Jesse.
So, Jesse, I guess I can't like fully respond to your question because really the inspection authority talked about in here is really just intended if there is an investigation that would require the board to assess something. So I think by and large, it's not intended to be proactive inspections at all. So in the instance that you've described, given that it was a one-off, I don't know that the investigation would include an inspection, if that makes sense.
Thank
Yeah, that
you.
makes sense. Thank you.
Maria, I'm hoping you make a motion. Just kidding. Not to put any pressure.
I have a question though, mostly because I think there's maybe some difficulty with the whole idea of space. Quite a few pharmacists that practice outside of a licensed pharmacy don't often have a designated space or office or clinic. Sometimes it's their laptop that goes with them to their home, to the patient's location, or to the clinic. So the laptop is portable. It's not necessarily like engaged to a specific hard space. So I think we probably need to say, if that's not acceptable, we need to say that. But if it is acceptable, which I hope it is, because that's pretty common practice, then I'm not sure how we can even talk about space.
I think it's related to remote processing for dispensing purposes, not necessarily in providing like clinical advice, consultation, patient education.
So that still happens with a laptop people take home. Now, oftentimes you have a home office, but it may be a laptop that's assigned to that shift rather than a space.
Okay, thanks, Maria. Maybe, I think we can still proceed just because you know how the rulemaking, as you well very know. I think my hope is that we get this going so that as this is a rulemaking process, we can continue the discussion and clarify as necessary, is my hope, if you all are agreeable. Okay, I see Satinder is passionately nodding his head, so hopefully he's bold enough to make a motion. Thank you, Satinder. It's very long and lengthy, as
To
always.
initiate a rulemaking to add California Code of Regulation Title 16, Section 1717.11 as proposed or consistent with the board's discussion. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business, Consumer Services, and Housing Agencies for review, and authorize the executive officers to take all necessary steps to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearings is requested, authorize the executive director to take all necessary steps to complete the rulemaking and adopt the proposed regulation at section 1717.11 as noticed.
Thank you, Satinder. And just for the clarification, you would like to at this point say as proposed, correct?
Yes, as
Okay,
proposed.
thank you.
Second.
Thank you, Ricardo. Members, any other full board discussion? Jesse, did you mean to raise your hand again? I'm so sorry if
Yes, I did. I know in the
Okay,
past
go
I've
ahead.
been pretty vocal opponent. I still feel the same way about remote processing. The feedback that I've gotten from a lot of pharmacists in chains that do use remote processing, even within the facilities, is that they're number one, unaware when they're verifying for another pharmacy, so a patient that's not their own. And the PIC is not aware that it's even happening. And now I note that there is some language here about the pharmacist in charge pharmacists in charge needing to approve the remote processing, but as it exists today, that doesn't really happen. And I'm just concerned with not only the pharmacist in charge, but also the pharmacist on duty ability to reject that if they really wanted to. And then the last note that is a little bit confusing for me is in section B. That last part where it says, for the purpose of this section, remote processing of prescriptions does not include final product verification, supervision of pharmacy personnel, or the dispensing of a drug. I'm a little confused as to what they mean by dispensing of a drug. And I don't know if that's actually handing a drug to a patient versus being part of the dispensing process. And maybe if we have some clarification, I don't know if there's a language cleanup that is needed or if I'm the only one seeing it that way, but that's a little confusing to me.
Thank you, Jesse. Do we have any other member comments? Okay, we're ready for public comment. But Jesse, as obviously rulemaking and as we discuss further, we will definitely get that clarified and making sure that it all makes sense. Members of the public in Anaheim, do we have any public comment? Seeing none, we are ready for public comment in WebEx. Shelley?
All right. For Are those of our members of the public in WebEx? If you would like to make a comment on this item, please utilize that hand raise feature by pressing on the hand raise button at the bottom of your screen. For mobile device users, you can access that feature through the ellipses. And for our call-in users, you can dial *3. Our first comment comes from Jackie Stover. Jackie, I've sent a request to unmute your microphone.
Hi, my name is Jackie Stover, and I'm a specialty pharmacist. I just wanted to say thank you to the Board of Pharmacy and everyone involved for making remote processing possible and putting it within our sites and drafts. I also wanted to express my gratitude to everyone who have invested the many long hours over the past years on AB 1503. Once again, thank you for your time and attention to this very important subject that has been close to my heart and mind for the last 2.5 years since the pandemic. Thank you.
Thank you for the comments.
Our next comment comes from John Gray. John, I've sent a request to unmute your microphone.
Hi, good afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. Very happy to see this topic back on the agenda now that AB 1503 has passed. Kaiser Permanente supports common sense regulations that would allow for pharmacists remote prescription processing regardless of practice setting. And so again, we're happy to see that that's the general direction that the board is taking. However, in our view, common sense does not include regulations that would contravene an individual's protection under the Fourth Amendment of the U.S. Constitution. And it seems that that is what this regulation would seek to do. Additionally, it's not clear to us under what authority, what existing authority in Business and Professions Code 4008, a Board of Pharmacy inspector would be allowed to enter a remote work site that is not one of the kinds of sites contemplated in that section of statute. So again, largely supportive of the direction, but have significant concerns about the proposed 171711 A2. Thanks very much for the opportunity to comment.
Thank you for the comments, Dr. Gray.
Our next comment comes from a call-in user with the last 2 digits of 44. I have sent a request to unmute your microphone. And you will have to hit *6 to unmute your microphone. There you go.
Hi, Board of Pharmacy. I wanted to thank the whole board for all their hard work and for advancing the section regarding remote processing. This proposal supports modern pharmacy practice and improve access care, and also ultimately will improve quality of life for pharmacists, which in return will return better patient care to our patients. I respectfully urge the board to expedite the rulemaking process as this model was proven successful during the COVID era waiver. So hopefully we can come to a conclusion soon. But I also just wanted to thank everyone for all their hard work for our profession and for our patients. Thank you so much.
Thank you for the comments.
And our next comment comes from Enos Anton. I sent a request to unmute your microphone.
Hi, my name is Ines Anton. I'm a California licensed pharmacist who work for a specialty pharmacy. I want to echo comment for Jackie Stover and Sophia. we thank the board for all the efforts they made about remote processing. We appreciate all the efforts. And of course, it doesn't include end product verification. We don't do product verification. We do consultation, we do DURs, we review charts, we do patient counseling, but we don't do any product verification remotely. We are so grateful for everyone who worked on the Sunset Report and AB 1503, and we really can't wait for this to be implemented in California like all other states. Thank you so much, and thank you for giving me an opportunity to comment.
Thank you for the comments.
And seeing no other requests, I'll return the floor to you.
Thank you, Shelley. Okay, members, we are ready for vote. Any comments before we go? All right. Jesse, how do you vote?
No.
Thank you. Trevor?
Yes.
Thank you. Renee?
Yes.
Thank you. Jeanette?
Yes.
Thank you. KK? Thank you. Claudia?
Yes.
Thank you. Jay?
Yes.
Thank you. Ricardo?
Yes.
Thank you. Satinder?
Yes.
Thank you. Maria?
Yes.
Thank you. Nicole?
Yes.
Thank you. And I vote yes. Motion passes. Next, moving to the standard of care and attachment 2, which include a recommended policy statement. So amended sections 4051 and 4052 related to standard of care will define accepted standard of care and transition some provisions for pharmacists provided healthcare services to a standard of care practice model as specified in section 4052. As indicated in the meeting materials, repeal of several regulations will be required. This will be achieved under the executive officer's delegated authority. You'll note that the committee is also recommending release of a policy statement related to the standard of care practice model in the specified areas of preventative health care. As I open for member discussion, I note that the meeting materials and meeting slide include a possible motion that could be used to approve the proposed policy statement. Welcome the discussion from members. It's attachment 2. Members? So move as well. Would work as well if you all just want to get on, but any comments? I don't see Jessie on the screen anymore here, so hopefully she's not dropped off.
Can you hear me?
Oh, we
Sorry.
can hear you.
That's weird. On my end, my video is working. Is my video not working for some reason?
I can see you, Jesse.
Oh, there you are now. Yes.
Okay.
I
Great,
think it's
thank you.
just not enough boxes. Okay. Any comments or anybody want to make a motion to approve the policy statement as drafted? Attachment 2.
I'll make the motion, so.
Thank you, Jesse.
Seconded.
Thank you, Trevor. Public comment in Anaheim. Richard, Dr. Dang.
Hi, thank you, Richard Dang, on behalf of myself. Policy statement's great. This is my only opportunity to comment 1503, so sorry if it's in the wrong place. So for the information put out by the board about updated information on pharmacists' authority to administer vaccines, there was some confusion caused by one of the statements regarding the 4052A11 that is going to be repealed because of 1503. That is the provision that allowed pharmacists to initiate and administer vaccines for under 3 years old by protocol. So I do appreciate on the website, the board provides clarity that in the new 4052A12, that the collaborative practice agreement provisions that allow pharmacists to initiate, modify, and discontinue drug therapy is inclusive of vaccinations. So for those who are confused about that, I just want to point to that section, and I appreciate the board being proactive and putting that in writing to resolve that. The next item is regarding another element of 1503 that hasn't really received a lot of discussion and conversation, so maybe it's more for education or consideration. But we've heard in the past from public comments that some pharmacists who do prescribe or furnish medications have encountered issues with health plans rejecting their prescriptions or other companies not accepting a pharmacist's written prescription. It is my opinion that this is addressed in 1503 under the new section 4040 that defines what a prescription is. Under that definition in the new revisions, it's inclusive of section 4052, which covers the entirety of pharmacists furnishing under standard of care. So I'm hoping that as 1503 becomes implemented, that the board can work with stakeholders to educate them on what the definition of a prescription is, and that it is inclusive of pharmacist-initiated prescriptions that are done under furnishing under standard of care by the new provisions of 4052. Thank you.
Thank you, Dr. Dang. Any other in-person comments? Seeing none, we're ready for WebEx. Shelley?
Thank you. If you'd like to make a comment on this item and you are joining us via WebEx, please access that hand raise feature. Again, that's a button at the bottom of your WebEx screen. If you're on a mobile device, you may need to utilize the ellipses. For call-in users, it's *3. And seeing no requests, I will return the floor to you.
Thank you. Members, we're ready for a vote. Jesse, how do you vote?
Yes.
Thank you, Jesse. Trevor?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeanette. KK?
Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Claudia. Jay?
Yes.
Thank you, Jay. Ricardo? Thank you, Ricardo. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. Nicole?
Yes.
Thank you, Nicole, and I vote yes. Thank you. I will work with staff to release the policy statement and ensure it is included in the upcoming dedicated issue of the script, which will be released in early 2026, which would include all the AB 1503's wonderful stuff that's in there. So look forward for that. So last action item under AB 1503 today is related to pharmacists in charge and staffing. Attachment 3 includes draft policy statement. So as indicated in the meeting materials, changes in section 4113 provides that the pharmacist in charge, PIC, shall make staffing decisions instead of may of the pharmacy. Further, section 4113 as amended requires the PIC to determine the appropriate pharmacist to technician ratio, which may not exceed 1 pharmacist to 3 pharmacy technicians. Among the implementation activities during the committee meeting, it was determined it is to be appropriate for the board to develop and release a policy statement related to the role of a PIC. Included in the meeting materials is a draft policy statement in attachment 3. As I open up for member discussion, I note that the meeting materials and meeting slide include a possible motion that could be used to approve the proposed policy statement. Members? Are we all lethargic from lunch? Probably. It's all understandable. Too much Chipotle over here in this location. Members, do we have anybody want to make a motion? Maria? Go ahead.
I move to approve the role of the pharmacist in charge policy statement as proposed. Period. That was pretty.
Thank you. Thank you. And oh, sorry, Jesse, I didn't realize you raised your hand. I'm gonna try to see how I can get a better view.
That's okay. I can second Maria's
Oh, thank you,
motion.
Jesse.
Yeah,
Thank
I just
you.
wanted to note that I really appreciate the board coming together to create this policy statement. I think there is a lot of confusion with some substantial law changes, and so I think this concise reminder will be very useful for both pharmacy licensees, but also for pharmacists as well.
Thank you, Jesse. Maria made motion. Jesse seconded. Members, any other comments? We are ready for public comment in person. Okay, we have one.
Relevant at this time. Lori Wamsley on behalf of Walgreens. As you contemplate the role of the non-resident PIC, I understand that you have the guidance that around who can serve as the non-resident PIC. As we are looking to come into compliance for our non-resident pharmacies, it has come to my attention that there is obviously a defined number of testing dates. There are only 4 dates before the law will be effectuated in 2026. So would like to encourage the board to look at additional dates. The CPGAE is not offered in every state, so it will require out-of-state travel for some of our non-resident PICs. So having additional testing dates would be extremely helpful for the regulated public to make sure that we're able to remain in compliance with the new law. Thank you.
Thank you, Lori. Appreciate the comments. Any in-person comments? We are moving to WebEx.
All right, for our WebEx attendees, please use that hand raise feature to request a comment on this item. We are displaying instructions on the screen. For our call-in users, that would be dialing *3. And seeing none, I will return the floor to you.
Thank you, Shelley. Jesse, your hand is raised, so I want to make sure I call you out.
Thank you, President. Just wanted to echo the public comments. I have also received that feedback from other non-resident license holders that the CPGAE dates may be a barrier. And so I would love to see us work with some of the non-resident licensees to, if there is a way that we can create more dates or just provide more flexibility, I think that would be helpful.
Thank you, Jesse. We will definitely take that and see what we can do with our staff. Okay, any other member comments before we vote? Seeing none, we are ready for vote. All right, Jesse, how do you vote?
Yes.
Thank you, Jesse. Trevor?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeanette. KK?
Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Claudia. Jay?
Yes.
Thank you, Jay. Ricardo?
Yes.
Thank you, Ricardo. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. Nicole?
Yes.
Thank you, Nicole. And I vote yes. Motion passes. Okay, so I'll work with staff to release the policy statement on this, as well as we're gonna see what we can do to make sure that some more dates could be available. And we'll provide further updates. Alrighty, members, given concerns about retaining a quorum, so we're proceeding to agenda item C. So that would be, we're moving to the summary of discussion of pharmacist to pharmacy technician ratio in the inpatient setting, including possible discussion and action to initiate a rulemaking to amend CCR Title 16, Section 1793.7. The committee continued its consideration of the current pharmacist to pharmacy technician ratio, and if an update to the ratio in the inpatient setting is appropriate. As the committee materials highlight, unlike the ratio in the outpatient setting, which is set in statute, the board establishes a ratio for the inpatient setting via regulation. Currently, the board's regulations have established a fixed ratio of 1:2. As a committee, we believe that the board should consider providing greater flexibility for the PIC of a hospital to establish the appropriate pharmacist to pharmacy technician ratio. I draw your attention to the proposed regulation language included in the meeting materials that will allow the PIC to establish the appropriate ratio. Such an approach appears generally consistent with the PIC delegation authority to establish a ratio in the community pharmacy setting. The proposed language also includes some non-substantive changes to reflect updates in some state department names. As I open for member discussion and comment, I note that the possible motion that could be used to initiate the formal rulemaking process is included in the meeting materials and hopefully displayed in the slide. Okay, members, any discussion?
This is Renee.
Thank you, Renee. Go ahead.
I just would like to say that I think this is a great direction to head for the hospital setting. The presentations that we received were excellent, really showing the diversity of what's happening in hospitals. So I would like to propose the motion.
Thank you, Renee. Go ahead, and I will let you do it. And Maria, I'll get to you after, but I think Renee is, if you're okay to read on,
Yes.
get your glasses on there.
I got my glasses on. All right, let's get it done. So initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1793.7 as proposed. and to direct the staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all
So
necessary
sorry, Renee. I think that's a wrong
steps. Am I reading
slide.
the
I
right-
am so sorry. I'm like,
You said ratio, right?
is it?
Yeah, so the ratio is 1793.7.
So that was my point.
There may be a
that
typo. I
was-
think okay, so sorry, guys. There's a typo.
I'm going between the agenda and then
Yes.
the agenda is numbered differently than the
It's
actual materials.
1793.8.
Okay, so you-
1793.8.
Yeah, okay. so
Sorry.
Happy to propose that one as well. But yeah, you said ratio, so I just jumped to that without,
We're on the right agenda item. It's just the slide has a typo.
So I'm confused because you were talking about agenda item D, but now we're making a motion for agenda item C. So the slides,
D.
I don't know which
Yeah.
agenda item you're on,
Okay.
ratios or D.
so can we just stick with ratios since we said ratios? I mean, but that is agenda item, D that I have here, but
Oh, I'm so sorry, guys. Yes, we jumped ahead on the item as we're shuffling things around. So we're gonna go with the item D.
Yeah.
So let's do that. So
I just want to make a note. I have
Okay,
to step out
that's-
briefly.
okay.
that's what I thought I had.
Thank you.
Or I start, so.
Go ahead, Renee. Yes.
Shall I continue? I think I knew. Do
Go
I
ahead.
start from the beginning again? Or,
Sorry, if you could start from the beginning again, and the
Sure.
motion that's on the slide is the correct one.
okay, not reading the slide. Okay, 1793.7, correct? Let me
Yes,
just
that's
look at it.
correct.
Yes, okay. So is the one that's in the materials not the same? I just want before.
It's the same one. Sorry,
Yeah,
I thought you
okay.
were reading from the slide.
No, I'm not. Initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1793.7 as proposed. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all necessary steps to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all necessary steps to complete the rulemaking and adopt the proposed regulations at section 1793.7 as noticed.
Thank you, Renee. So sorry for the confusion. So we're on agenda item D, 1733.7. Maria, was that the comment you wanted to add?
Yes, I don't mind seconding, but I hope that we do have some time to talk about agenda item C, because I have a lot of
Yes.
comments on C.
Yes, we'll go back to the C.
Okay, so I do agree and thank everybody and second it.
Got it. Any other member comments? For our public, it is on agenda item D, under 13D. Any public comment in Anaheim? Seeing none, we are ready for public comment in WebEx.
All right, if you'd like to make a public comment and you are joining us via WebEx, please utilize that hand raise feature at the bottom of your screen to raise your hand. For our mobile users, you can access that feature under the ellipses. And for our calling users, you can dial *3. And seeing no requests, I will return the floor to you.
Thank you, Shelley. Okay, we're ready for vote. Are we ready, members? Any comments? Okay. Jesse, how do you vote?
Yes.
Thank you, Jesse. Trevor is just stepped outside. Renee?
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo. Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Okay, we're moving to agenda item C. Again, apologies. it's not in my head. 7 came anyway. So it's 8 now. So summary of discussion of California Code of Regulation Title 16, Section 1793.8 related to technicians in hospitals with clinical pharmacy programs, including possible discussion and action to initiate a rulemaking to amend Section 1793.8. As included in the meeting materials as part of the meeting of the committee, continued its discussion on the important role pharmacy technicians play in hospitals. The meeting materials highlight several relevant provisions of pharmacy law, and a brief background is provided in reminding members about the actions the board has undertaken to evaluate the critical role pharmacy technicians play in supporting pharmacists and changes made to the authorized functions of pharmacy technicians. As a quick reminder, as part of the committee's June 2025 meeting, the committee received 4 fantastic presentations from different hospitals, including Stanford Healthcare, Cedars-Sinai Medical Center, UCSD Health, and Kaiser Permanente Enterprise Pharmacy. It was clear from the presentations that the pharmacy technicians play a critical role in their respective hospitals in supporting pharmacists and patient care services. The presentations discuss technology used in assisting pharmacy operations and more expansive roles pharmacy technicians are playing in a number of areas, including medication reconciliation and prior authorizations. It was the information shared during these presentations that served as a framework for the recommended changes being considered today. I draw your attention to proposed regulation changes being recommended by the committee to incorporate changes and develop a regulatory model to allow for a pharmacist in charge of a hospital to determine additional non-discretionary tasks that a pharmacy technician may perform in a hospital with a clinical pharmacy program. As I open for member discussion and comment, I note that the meeting materials include a possible motion that is also displayed on the slide. So that's now 17. Okay, it's the right one. Okay, Maria, your hand is raised.
Yeah, thank you. I wanted to go first because, first of all, I wanted to thank the committee and all the presentations. They had a very robust discussion. This is an area that's very near and dear to my heart. So I have several suggestions to make minor adjustments to assure that we do not unintendedly impact current practices in hospitals that are very successful. Some unintended things that I would hope we could avoid. So I'll just go through them quickly if that's okay.
Go ahead.
Okay. In number 2, in number 2B, no, sorry, it's not 2B. B and B, they're all lined up together. I do appreciate the committee's decision to specifically call out compounded and repackaged drugs as needing to be checked by a pharmacist before they're being utilized for patients. That's excellent. But I do suggest that the sentence end at technician and that the words to fill unit dose distribution systems, floor stock and ward stock be struck. It was already struck above in A. And so I think that to be consistent and to avoid differing standards in hospital practices, it should be struck from item B also, so that the sentence would end at technician, period. That's the first one. The second one is in A. There's information there that was struck that I think is valuable and should be maintained. So I would suggest that it be moved into a new C, that the C would say, all patient orders must be previously reviewed and verified by a licensed pharmacist prior to being filled by the technician. That's something that I think is the intent. It's struck from A, and I would suggest that we keep that wording somewhere, and that would be a new C. Those are the most bigger suggestions. The other 2 are kind of more discussion items. In number 2, the word inpatient care setting is really not an appropriate term anymore. Hospitals take care of different types of patients. Inpatient is just one of them. They take care of emergency room patients. They take care of infusion center patients. They take care of same-day surgery patients. Those are not inpatients. So I would suggest changing the word from inpatient care to either patient care or hospital patient care. I think it'd be easier to just say patient care. And the last issue is, I think I didn't really understand the discussion at the committee, but the word non-discretionary, which is an A, non-discretionary tasks, and I'm not quite sure how that would be interpreted by attorneys because the practice that we're talking about is discretionary. The technician is in some situations checking the work of another technician, and they're assuring that the dose is correct. The Tylenol 325 is not a Tylenol 500. The metoprolol is immediate release and not extended release. The isosorbide is a mononitrate, not a dinitrate. To me, that's discretionary. So if you want to educate me to tell me that that's non-discretionary, then I'd be willing to hear that. But my concern is I don't want to have any unintended consequences by later someone saying those are discretionary, so techs can't do it, even though they're doing that today. Thank you. Lots there, sorry.
Thank you, Maria. That's probably have few discussions to have, but any other comments?
Hi, Maria. Thanks. I think those are really great suggestions. And I agree with your edit for 2 about shall deploy pharmacists, and suggest that maybe it could be even more general as to say shall deploy pharmacists to provide clinical services. Anyway.
So I think the
Well-
challenge, okay. Is that it, Renee?
That wasn't
Did
one
you
of my
have any-
comments, so I think that's a new comment, Renee.
Well, I think
Isn't it? Go ahead.
you were saying to not be inpatient care setting. So
Yeah, I think it's just patient care setting would be appropriate, correct?
I mean, I would agree with that too. but
Yeah.
I think it could be since it's to provide pharmacists opportunities for clinical services.
So that I agree with all of those comments. I think the only thing that I'm unsure how we would proceed is about your comment about non-discretionary tasks. So I think the intent of it was that we would like to provide as much flexibility for the PICs. Do you want to say something? Go ahead.
It is defined right below. And do we intend to have more activities done by a technician at the discretion of the pharmacist, or do we just want to not describe at all so pharmacists can basically subscribe more items to the technician?
So I think some of the challenge, Jennifer, you're going to need to jump in, but I think some of the challenge is that the statute already defines. So we have to acknowledge the non-discretionary tasks included in the statute. And so that's kind of what some of the language is. And I think that the intent was we have to acknowledge those, but then we can identify additional tasks. One of the comments that I heard Maria talk about, and I think Renee had made a similar comment during the committee meeting, was the whole concept of the tech check tech. And I think in trying to streamline, we kept it in one area, but probably like removed too much of it in another section. So similar to where Maria is suggesting that, one of the other provisions become a standalone, we could just restore the tech check tech as a standalone subsection or whatever.
Maria?
yes.
Oh, go ahead. Oh, sorry. Go ahead, Jennifer.
Oh, sorry, I was just going to second what Ann said. Because the Business and Professions Code section and an additional CCR section defines what the non-discretionary tasks are, this was bringing in those 2 sections, but if the board would like to further elaborate within this section additional meanings or elaborating more tasks, open to that. However, if the board would also like to leave it more discretionary for the pharmacist to determine, that's how the language currently is.
Thank you, Jennifer. Satinder, go ahead.
I think I remember from the discussion that the reason we left it at the non-discretionary was that because there were a lot of examples during the presentation that were given where the techs could be doing the more tasks and allow pharmacists to do other duties. So it was, I think we incorporated as a way for them, for hospitals to have policies and procedures and describe what those are, and allow the PIC to have the discretion to leverage technicians for other duties.
Thank you, Satinder. Jesse? And then I'll go to you, Maria.
Thank you. I think I agree with Maria's initial comments because I get the same impression reading it as the way that Maria had described it, in that I think something like tech isn't necessarily non-discretionary. And I think that as it's presented here does provide a little bit confusion. I understand wanting to keep it open, and maybe we incorporate like a separate section for that tech, and maybe, I don't know if it's also like possible in addition to that to provide a separate section to provide more flexibility, or to say like discretionary and non-discretionary tasks. I don't know if that provides more flexibility. But just wanted to throw that in there, that I agree with Maria's initial comments on the confusion.
Thank you, Jesse. Maria?
So I appreciate Anne's fix to this. I think that leaving non-discretionary is important because that is all the things that you heard in the presentation and that I'm familiar with technicians do, but that now has made discretionary check no longer possible. So adding a new bullet point somewhere to maybe not go into the detail that was there, but to talk about it specifically so that someone doesn't come later and tell hospitals that they have to stop their program.
Good point. Okay, members, any other comments before we try to figure out where we're going to go? Okay, so there's two paths here. I think we can just bring this back to the committee and have a further discussion. Or another option is for us to just push forward here from what we discussed and start to initiate the rulemaking process, as that's kind of, I mean, it's a rulemaking process, so I don't think it's going to be, we're not never going to start this rulemaking process perfect. So just keep that in mind. So I'm okay with either direction, really. So I will let you all decide. Maria, did you mean to raise your hand again?
Yes, because
Okay.
I feel comfortable making a motion as long as we have consistent with the discussion. I think that Jennifer, Ann, and you or myself could assist with making those minor adjustments
Why
rather
don't
than
we?
going back to committee.
Yeah, I mean, if you feel comfortable, I'm happy to delegate to you for as a member, and you can delegate yourself to work with the EO to fine tune the language before the rulemaking packet goes out.
I would appreciate that as the acute care pharmacist on the committee.
Sure.
That would be very great. Thank you. So you want me to read it?
Go ahead.
Initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1793.8, consistent with the board's discussion. Direct staff to submit the text to the Director of Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all necessary steps to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all, and I can't see the rest of the sentence. That's the end of my slide. I'm sure it's cut off.
Executive officer to take all necessary steps to complete the rulemaking and adopt the proposed regulation as Section 1793.8 as noticed. Is that sufficient for you, Maria?
Yes, that's just, it doesn't
Okay.
come across on the slide on.
Did you add your delegation? Sorry if I missed that.
So the part that would be consistent with the board's discussion would be to delegate to member SERPA to work with the EO and staff to, not coordinate, to apply the board's
How about
discussion.
to finalize the language prior to
There we
notice?
go. Thank you.
Thank you, Anne. Thank you, Maria. Do we have second?
I'll second.
Thank you, Renee. All right, members. Any other discussion on this? Seeing none, we are ready for public comment in Anaheim. Seeing none, we're ready for public comment in WebEx. Shelley?
Anybody on WebEx would like to comment on this motion, please use that hand raise feature, locating the hand raise button at the bottom of your WebEx screen. For our mobile users, you can access this feature through the ellipses, and for our call-in users, you may dial *3. And seeing no requests, I will return the floor to you.
Thank you. I think it stayed up from the prior, but Maria, your hand is up, so I just wanted to make sure you didn't have any other comment. Up, okay, thank you. Jesse, how do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo. Thank you, Satinder.
Yes.
Thank you, Maria. Maria, now that you're,
Yes.
yeah, there you go. Nicole.
Yes.
Thank you, and I vote yes. Motion passes. Okay, we're now moving to the almost last item on licensing committee. Summary of discussion of proposal to establish definitions for pharmacies based on business model. The committee also initiated discussion and consideration on a proposal to establish definitions for pharmacists based on business models. As included in the meeting materials, generally the requirements for pharmacies apply equally among a variety of business models unless otherwise specified. This approach allows for broad regulation yet can become challenging when business models vary, but requirements many times do not. Within existing law, there are several instances where a more specific definition is referenced, but only when applying to a specific provision of the law. The meeting materials also provide an example. Pharmacy law does not currently include a general definition of chain community pharmacy. Rather, in specified sections of statute and regulation, the law refers to BPC Section 4001 for the definition. Note, BPC Section 4001 provides for the purposes of this subdivision, a chain community pharmacy means a chain of 75 or more stores in California under the same ownership, and an independent community pharmacy means a pharmacy owned by a person or entity who owns no more than 4 pharmacies in California. Different jurisdictions nationally have taken varying approaches, with some jurisdictions, such as Texas, issuing separate licenses for different classes of pharmacy licenses. On the other hand, Nevada issues a single pharmacy license that covers a variety of different types of business models. Nevada requires disclosure of the types of services, though. As a committee, we noted some of the benefits to develop definitions, which include providing better transparency to members of the public about service availability and allowing for more precise regulation of some requirements. Any proposal to add definitions will need to be implemented either through regulation or statutory changes. The committee intends to continue its discussion during its next meeting, and I just want to say I appreciate the public comment, the written comments submitted by one of our stakeholders. So appreciate that. We will use that for our future consideration at the committee level. Members, do we have any comments on this item? Nope. All right. Seeing none, we're ready for public comment in Anaheim. No public comment in Anaheim. We're ready for public comment in WebEx. Shelley?
If you would like to make a comment,
there.
please use that hand raise feature. We are displaying instructions on the screen. And seeing no requests, I will return the floor to you.
Thank you. Okay, next agenda item is summary of discussion of infusion center pharmacies and possible changes to pharmacy law to create a new licensing program. This goes really hand in hand with the other items, so in the future, we'll be combining the two discussion. The committee moved to discussion of the potential creation of a new licensing program for infusion center pharmacies. As noted in the meeting materials, the board has previously received comments that the board's current requirements for pharmacies create barriers to patient care for pharmacies that prepare infusions for administration to patients and infusion centers. As part of the committee's discussion, members requested that stakeholders provide specific examples of barriers caused by the board's current regulation of infusion center pharmacies. I would like to confirm that you received the written comments that were submitted after the meeting materials were released, and the written comments provide examples of barriers to patient care and current requirements that are established for infusion center pharmacies that are not necessary, such as patient center labeling requirements, noting that the infusions are provided in infusion centers administered by healthcare providers. I note that the conclusions from this letter suggest that the current licensing framework fails to capture the operational realities of modern infusion centers, and that creation of a distinct infusion center pharmacy license would modernize oversight, remove irrelevant retail obligations, and focus regulatory oversight on areas most directly related to patient safety, such as clinical safety, compounding, and sterility practice, and patient access. So the committee is not recommending any committee is not offering any recommendation. If you guys have any strong feelings or any comments or suggestions on this agenda, please voice your thoughts now so we can hopefully have a further discussion at the committee level. Maria?
Thank you. I look forward to the further discussion on this because I think that there is not one single pharmacy practice for infusion pharmacies. It's kind of a continuum. And so talking about the different levels or different programs that are in infusion pharmacies would be very beneficial. For example, the infusion pharmacy that I was most recently familiar with was solely dispensing medications to an infusion clinic. There was no patient dispensing, and that's one business type. I understand there are some infusion pharmacies that marry the providing of medications to infusion centers along with discharge, quote unquote, outpatient, whatever you want to call them, prescriptions. So it's not as straightforward as having, one infusion pharmacy is exactly the same as another infusion pharmacy. So I look forward to the discussion.
Thank you. Yep, and your observation makes it a little complicated for us to how to move forward. So we'll have more discussion on this item on how best we would proceed. Bless you. Any other comments? Seeing none, we're ready for public comment in Anaheim. Seeing none, we're ready for public comment in WebEx.
All right, if you'd like to comment on this, please raise your hand using that raise hand icon. Again, we are displaying instructions on the screen. And while I wait to see if anybody else has a comment, Paige Talley did send through another message. She had more significant technical issues and couldn't hear the meeting, so she logged off, but she did send an email with a comment if you would like me to read it.
Okay, well, we can also just receive a written comment as part of the rulemaking process as well. So I will defer that to Corinne.
I'm not sure what topic her comment was made on.
It's on this one. That's why I waited.
Oh, this topic.
yeah,
Oh, sure. Go ahead. Yeah.
Go ahead and read it.
It's got to be 3. Well, I think that we could just receive that in a written comment. I think chat is not really something that we're trying to
No, she
use
sent me
as
an
much as
email. I can
possible.
forward the email to the EO.
Yeah. Okay. Sounds good.
And
Was
not
there
seeing
any other
any other
comment?
requests.
Okay.
Nope, I'll return the floor to you.
Perfect. Thank you, members. Next is summary of discussion of application. As you can see, we had quite a meeting at licensing committee. Application requirements for advanced practice pharmacist licensure, including possible discussion and action to initiate a rulemaking to amend California Code of Regulation Title 16, Section 1730.1. The committee also considered the requirements for advanced practice pharmacist licensure. The meeting materials detail out the relevant sections of pharmacy law related to this agenda item. As noted in the materials, since implementation of the board's APH licensure program, the board has performed post-implementation review to evaluate barriers to licensure. Given the scope of practice for an APH expands way beyond initiating, adjusting, and discontinuing therapy, the committee believes it is appropriate to amend the requirements of 16 CCR Section 1730.1A3 to more accurately reflect relevant experience earned as part of a CPA in preparation for APHA license or advanced pharmacist practitioners. I draw your attention to the meeting materials, which include possible changes to regulation text recommended by the committee, in addition to the substantive changes reflected in the attachment. Non-substantive changes to update the title to Advanced Pharmacist Practitioner will also be necessary. As I open up for discussion, members, I note that the included in the meeting materials and displayed on the slide is a possible motion. Again, I'm sorry, Anne, you're going to have quite a regulation package to put together after this meeting. So, well, hopefully, members, anybody have any comments or would like to make a motion?
I'll make a motion.
Thank you, Trevor.
I move to initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1730.1 as proposed. Direct staff to submit the text to the Director of the Department of Consumer Affairs and Business, Consumer Services and Housing Agency for review, and authorize the executive officer to take all necessary steps to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the proposed procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all necessary steps to complete the rulemaking and adopt the proposed regulations at Section 1730.1 as noticed.
Thank you, Trevor. Do we have a second?
Second.
Thank you, KK. Okay, members, seeing no hands raised in WebEx, seeing no other comments, we're ready for public comment. Dr. Deng? That's okay.
Hi, Richard Deng on behalf of myself. I am an advanced practice pharmacist, and I also teach several of the APH certification programs. I am in full support of this amendment and motion. As President O mentioned, the APH scope involves other things other than initiating, adjusting, and modifying discontinued drug therapy. So there are current individuals who are precluded from applying because they may be engaged in other activities, such as the evaluation and management of diseases that may not involve initiation and adjustment of medications. Additionally, applicants who have applied and submitted their collaborative practice agreement over the last few years have experienced application delays as board staff have rejected their collaborative practice agreement because it does not specifically include the words initiate, adjust, modify, or discontinue drug therapy and that exact language. And so if applicants who have the experience, who have a CPA that says that they're allowed to engage in comprehensive medication management services, have had to go back to get their application rejected. They've had to go back to their health systems or pharmacies to amend the CPA, which can take quite a while before they reapply again, resulting in licensure delays of otherwise qualified individuals. So this amendment would reduce that barrier of entry and make it easier for those who do meet the qualifications to actually achieve this licensure. Thank you.
Thank you for the comments, Dr. Deng. Any in person? Ready for WebEx? Shelley?
Thank you. If you'd like to comment on this item, please use the hand raise icon at the bottom of your screen. Our mobile users can access that through the ellipses, or our calling users can dial *3. Our first comment comes from Sean Kim. And Sean, I've sent the request to open your microphone.
Good afternoon, board. Sean Kim from CPHA. CPHA appreciate the board's ongoing work to strengthen and promote the advanced practice pharmacist, soon to be an advanced pharmacist practitioner. We would like to respectfully request a clarification on nomenclature. According to the last licensing committee meeting, my understanding is it will stay as APH rather than changing to APP. But broader public notice will be helpful to resolve any outstanding questions. And just like echoing to previous comments by Dr. Deng, CPHA also fully supports the proposed amendments to 16 CCR 1730.1, which modernized the documentation process and flexibility in verifying as well as earning qualifying clinical experience through amended application requirements and align the evolving standard of care model under AB 1503. We also would like to highlight a practice gap related to the recognition and the privileging of advanced practice pharmacist credential. Unfortunately, Medi-Cal state plan amendments, SPAs, is not currently recognizing APP as a distinct license type, as well as the commercial plans, including Medicare Advantage. So it should be aligned accordingly in order for APP to practice as fully intended what they're supposed to do. So CPHA strongly encourages the boards to coordinate and relevant state agencies to support the implementation and the payer recognitions for advanced pharmacist practitioner credential as intended. CPHA values continued collaboration with the board and ensure the APP program remains rigorous and accessible for pharmacists delivering advanced clinical care across California. Thank you.
Thank you for the comments, Dr. Kim.
And with that, I don't see any other requests for comment, so I will return the floor to you.
Thank you, Shelley. We're ready for vote, members. Jesse, how do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you,
Yes.
and I vote yeah. Thank you. Thank you. I know it's been a long day. Thank you, and I vote yes. Motion passes. Okay, next is summary of discussion of licensing statistics. Wrapping up my reports from the licensing committee included in the meeting materials is a summary of the licensing statistics for the first 3 months of the fiscal year and 3-year fiscal year comparison data, which is very useful. So hopefully you all look at that. Processing times for the various facility business types vary. While a few of the licensing programs are within the board's performance targets, others exceed the 30-day target. As a reminder, the processing time noted in the meeting materials represent the oldest application of each type. The average processing time is lower. I just want to shout out to all the licensing staff for working so diligently to process applications. Overall, licensing statistics reflect a 2% decrease in the number of individual applications received and a 44% increase in the facility applications, but that's primarily driven by changes of ownership for chain community pharmacies. The number of individual licenses renewed increased by 4%, and the number of facility licenses renewed increased by 3%. Members, any comments? Seeing none, we are ready for public comment. In person, seeing none, we're ready for public comment in WebEx.
Thank you. If anybody on WebEx would like to comment on this item, please utilize that hand raise feature. Again, we are sharing instructions on the screen. For our call-in users, you can dial *3. And seeing no requests, I'll return the floor to you.
Thank you, Shelley. Okay, that concludes the licensing committee's report. Thank you for bearing with us here. All right, next agenda item is 14, Organizational Development Committee. We're almost there, guys. So Organizational Development Committee report is for information only, so I will keep my comments brief and open up for board and public comment at the end. The meeting materials include budget information for the new fiscal year that began on July 1st, 2025, as well as final budget figures for the fiscal year 24-25, which ended June 30th of 2025. The board's authorized expenditures are anticipated to be about $35.2 million this year. The board's fund condition is expected to increase slightly at the end of the current fiscal year. According to the report provided by the DCA, the board's fund currently has 8.2 months in reserve, which is a slight increase. As a reminder, under the provisions of BPC 4400P, the board shall seek to maintain a reserve equal to approximately 1 year's operating expenditures. I note this increase in the board's fund condition reflects in part the board's new fee structure that became effective January 2025. We will continue to monitor the fund and, if necessary, make adjustments in future years. And member attendance and mail vote information is included in attachment 2 and 3. I am truly, truly grateful to everyone for their time and commitment to protecting California consumers. And some personal update, the board currently has 5 vacant staff positions. Recruitments are ongoing, and I receive regular updates on recruitments. And I know that we are doing much better than where we were a couple years ago. So I know they're all working very hard to fill all those vacancies. And lastly, there is a updated meeting calendar for the next year. So hopefully you all can mark your calendar for our meeting dates. Members, any questions or comments?
I have a question.
Go ahead, Trevor.
So Anne and staff, for just curious with the fund balance, so doing back to the napkin math with revenue and expenditures for 24-25, it seems like there's, so again, just back the napkin math, 35, 6, 7, 8, about $40 million in revenue for 2024-25, and about 30-ish million expenditures. So, I mean, we'll just, again, back in the napkin, $9 million more in revenue than expenditures-ish. But the general fund only increased by 2 million approximately, or $1.5 million. So I'm just wondering, where does the extra revenue that was collected but not spent go, that doesn't go into the fund balance?
Yeah, so it will go into the fund balance. We had a couple of budget augment things that kind of happened over the last fiscal year, including the reduction of, authorized positions and things like that. So authorized expenditures were decreased. And then there was some cost savings measures. So we actually did not expend to our full authority. So that is part of the redirection back into the fund because we didn't spend the money that we were authorized to spend, if that makes sense. The other thing is we're still in projection mode kind of with respect to the restructure of our fees. And that's because they've only been in place for about 6 months. So we're kind of guessing a little bit in terms of what our revenue will be because we have not realized what that full fee structure will be. I do just also want to kind of note that I think our revenue potentially is going to be a bit volatile. We've had a closure of a significant chain community pharmacy, so we're going to have less revenue there. In addition to that, there's been some changes in that will impact our revenue, including we're no longer going to be licensing ads in emergency rooms based on the legislation in 447. And then we're looking at the provisions of implementing in 1503 related to pharmacy deserts. So I do think that our revenue is going to be, we're going to find a new normal, but there's a lot that's changing right now. So it's still, it's always an estimate, but now it's even more of an estimate, if that makes sense. I do think that it does show, historically, we've been very mindful of slowly working to restore our fund, right? When the board made its decision to recast fees, it was slow and steady is going to win the race in terms of restoring our fund. We're going to have to probably reevaluate that a little bit.
But going back to like, not the projections, but what we specifically got in revenue that exceeded expenditures in 25. So are these numbers for 25, fiscal year 25, are those still projections or are those not?
Fiscal year 24-25 is done. We've just started 25-26.
Oh yeah, so I'm looking at the 24-25 numbers.
Yeah, so we didn't fully expend what our authorized were. We also received, there are certain kinds of revenues that you don't necessarily anticipate, but you receive. And a really good example of that is citation and fine.
Right.
So, 1.2 million in citation and fine revenue or whatever. Sorry, I'm not looking at the numbers. I'm trying to look at you.
Yeah.
But all of those kinds of things will also increase your projected, your actual revenue beyond probably what you projected because you don't want to balance your budget based on fines and those kinds of things.
Right. So where does the excess between the revenue and expenditures go?
Into our fund.
Yeah.
Which
So
is like our
that,
savings account.
Right.
so that's why our month-end reserve has gotten much better.
Right.
Because of little by little, but the reserve numbers are always projecting out with certain percentage increases on expenditure without growth in revenue.
Got it.
So that's why this number always fluctuates.
Got it. Okay.
Any other member comments? No, Trevor, our money just goes into sky goes.
California state government, what can you say?
Okay, seeing no comments, we're gonna go for public comment in the room. Oh, sorry. God, this so tiny. Claudia, go ahead.
Just wanted to follow up. I did see that, for example, we are projecting, it says Department of Consumer Affairs. We're projecting that it could go up to 39 million a year in 2028, 2029. Is there something in particular that's changing? Is it just what we pay to staff and cost of living that we have to accommodate for? Anything that we should be aware of?
I don't think so, Claudia, but I'll let Anne speak on that, but I don't think so.
Yeah, so generally, and through our fee audit and the work that was done by that independent contractor, looking at historically, you are going to have increases in expenditures over time. Sometimes that's related to salaries. Sometimes that's related to the cost of doing business, facilities, those kinds of things. If you're talking specifically about pro rata, you know that those are things that are assessed to the board for centralized services, both within the Department of Consumer Affairs as well as the state. And so when we're talking about like increases in salaries, right, that's going to increase both our personnel costs, but it's also going to increase generally like our pro rata because we're paying for services that now cost more. Does that kind of make sense?
Yeah, definitely, just so we can be aware that's coming, because I know that puts us at, let me see, what's the number? 3.2 months in reserve from 8.2. So just wanted to point that out. And do we have, I mean, have we gone below 3.2 months in reserve historically, or? Because it doesn't feel like we should be comfortable with 3.2 months in reserve.
Yeah, so great question, Claudia. I'm happy to get back to you with that. We have been very low before. Our fees are at generally at their statutory minimum. So if we do need to raise fees, we do have the ability to do that through regulation as opposed to going back to the legislature. But like I said, our revenues are kind of in flux right now because we don't have a full year's worth of data in terms of our fees at the recasted fee schedule. So I think probably in another year after like the ads settles out, the loss of the Rite Aid settles out, and the new fees, we'll probably have a better sense of where we need to go, if that makes sense.
Yes, thanks for clarifying. I appreciate that.
And for anyone wondering, I know our staff does an amazing job of really ensuring that they're very careful on budget and be conscious of our reserve fund situation. Okay. I think that's it. We're ready for the next agenda item. Did we do public comment? Oh, because Claudia, that's right. Okay, we're going back to public comment on WebEx.
If you would like to make a comment, please utilize that hand raise icon on your screen under the ellipses for mobile users or *3 for our calling users. We do have a comment from Sean Kim. And Sean, I've sent the request to unmute your microphone.
Thank you. On behalf of CPHA, thank you to the board and the staff for your continued dedication during these unforeseen challenging times. We're confident that pharmacy profession in California is moving to the right direction and gaining the recognition from our healthcare colleagues and the general public. As discussed today, there are some important initiatives that has to be implemented in the near future, but we look forward to continue this productive conversation in 2026. Thank you.
Thank you, Sean.
And seeing no other requests, I'll return the floor to you.
Thank you. We're almost there, guys. Agenda item 15, Executive Officer Report. I will turn the meeting over to Anne for a brief report. So this is when she's gonna talk very fast.
So I know we're tight on time. I'm feeling pressure right now. Okay, so included in the EO report are updates on a number of items for your review, including some cures data, CAMER reporting data, status of regulations, information on the joint listening session that we convened with the California Veterinary Medical Board, as well as implementation of Proposition 34. I would like to highlight one of the items in there specifically is related to the joint forum. So an announcement has been released regarding the joint forum that is December 17th. Registration will open in about 2 weeks, and because space is limited, I would recommend that individuals interested in participating register early. And back to you, President O.
I cannot believe you did not share with us, though, that you were elected as a NABP District 8 chairperson. So she will be serving in that role as a NABP District 8's chair, along with me as a treasurer. So now I get to call her my boss. Thank you, Chair Sodergren. Okay, members, any comments for Anne? Seeing none, we're ready for public comment in person. think everybody's exhausted. We're ready to go home. In person, none. We're ready for WebEx, public comment on WebEx.
If you'd like to comment on the EO's report, please raise your hand using that raise hand icon feature at the bottom of your screen, through the ellipses if you are on a mobile device, or by dialing *3 if dialing in on a phone. And seeing no public requests for comment, I'll return the floor to you, and Maria Serpa has her hand.
Oh, thank you, Shelley. And I also want to remind everyone, really, this joint forum for December 17th, I think will be great. So I hope all our board members to please come, and all the public pharmacists to please register and join. And then I'll go to you, Maria.
Yeah, I should have mentioned, but if you have an opportunity to read Ann's report about the joint veterinary board of pharmacy listening session, was very successful. Large numbers of attendees, most of them remote. Veterinarians had questions regarding access to some very unusual types of medications, and there was a person from the Veterinary Association who provided some assistance on where to access things and how to request them. But also Ann has added assistance to veterinarians on where to access medications, what vendors provide it through the 503B process. And I thought that was very helpful, that the Board of Pharmacy is seen as more being helpful instead of being resistant and causing all of drug shortages. You know, we know that the pharmacy board does not cause drug shortages, but the board is really reaching out not only to human patients, but to animal patients to help them too. So thank you everyone who have participated.
Thank you, Maria. Thank you for participating in that as well. Okay, members, we are at the end. So thank you to the public for your participation today. Thanks for all of you to coming in person, to all the attendees in WebEx. Thank you to all our members for flying here and driving. Thank you all for all you do. Thank you to members joining via WebEx. So hopefully we'll see you in January. I cannot believe. Happy Thanksgiving, Merry Christmas, Happy New Year, all the holidays in between. Hope you all have a great rest of the year. Thank you. Meeting is adjourned.
Thank you.